Chalo. So let's talk about ENT further. So the question 1 says, beta, we are having a 37-year-old female who came to us with complaints of decrease in hearing, that is hearing loss, along with pulsatile tinnitus. Tuning fork test was done beta, and it reveals the patient is having a negative Rene, and the pure tone audiometry shows that there is a poor air conduction. On examination, a reddish mass has been observed behind the intact tympanic membrane. What would be the likely diagnosis? Now, if they ask you, definitely beta, what are the hints in the question? We know the first one, the patient is a young female beta. Second important, the patient is having hearing loss. Third important, most important keyword of the question is pulsatile tinnitus beta. Okay, I have told you already that whenever they say pulsatile tinnitus, okay, we know it is more likely to be a vascular tumor growing inside the patient's ear beta. Barabar? Whenever there's a vascular tumor growing in the middle ear of the patient will have this finding of pulsatile tinnitus. Tuning fork test which was done beta, it reveals the patient is having negative Rene along with PTA showing you poor air conduction. I hope all of you are quite aware. Whenever a patient comes to us with hearing loss, the first two tests that we do beta, one is the tuning fork test, second is the audiometry beta. Either of that test can also be done. Here both of them were done beta, and it is found out that the patient is having a negative Rene. Negative Rene ka matlab hota hai, we know in a tuning fork test beta, we will keep the vibrating tuning fork in front of the patient's ear beta, and then we will ask the patient whether he was able to hear the sound or not. That is air conduction. Second time, I'll keep the vibrating tuning fork beta on the patient's mastoid bone, and then I will ask him whether he was able to hear the sound or not. Okay, that is bone conduction. Now, whenever I ask my patient to compare air and a bone conduction beta while performing a tuning fork test, that is called as the Rene's test. Now in Rene, basically, normally what the patient would say, that the air conduction was much better than the bone conduction. Why? Reason beta, in bone conduction definitely, as the vibrations of the sound has to travel via a solid medium like bone beta, the sound of the vibrations usually get diminished. बराबर इसीलिए definitely normal patient में or a normal person में beta, always air conduction is much better. And whenever air conduction is better beta, we know this is called as a positive Rene. But if a person is suffering from CHL, that is conductive hearing loss, we know beta, conductive hearing loss means any pathology or any problem either in the external ear or the middle ear beta of the patient. Now hopefully the screen is visible. Chalo, hopefully now it is good. So again beta, as I was talking about, that please remember whenever you perform a tuning fork test, you have to do two tests beta. First, keep the vibrating tuning fork in front of the patient's ear, that is called as the air conduction. Second time, keep the vibrating tuning fork on the patient's mastoid bone, that is called as bone conduction. Normal person may, he will always say that his air conduction was much better than the bone conduction, and whenever the air conduction was better beta, it is called as a positive Rene. But if a person is suffering from CHL, that is conductive hearing loss beta, we know he will say that Dr. Saab, my air conduction is poor, whereas the bone conduction would be normal. Reason, we know beta, conductive hearing loss means any problem that happens in the patient's external ear or the middle ear. So whenever there is a problem in the patient's external or middle ear beta, obviously the sound will not be able to conduct via the external or middle ear, and that's the reason the patient will suffer from a conductive hearing loss. But please remember beta, when we check for bone conduction, during bone conduction, the sound or the vibrations directly reach the patient's inner ear beta, okay, that is to the cochlea. And therefore, in a patient who is having conductive hearing loss, he has no problem with the cochlea or the inner ear beta. That's the reason his bone conduction would be absolutely normal. So in a person who is suffering from CHL or conductive hearing loss, हमेशा याद रखना that the patient's air conduction is always poor and his bone conduction is always normal. And as the patient's air conduction is poor beta, that's the reason when you ask him to compare, he will say that Dr. Saab, my bone conduction was much better than air conduction. As his air conduction was very poor, that's the reason he will say, Dr. Saab, my bone conduction was much better than air conduction. And whenever bone conduction is better than air conduction beta, that is called as a negative Rene beta. That is classically known as the Rene negative. Clear? And negative Rene is only and only a feature of CHL, that is conductive hearing loss. Negative Rene is only a feature of conductive hearing loss. And we know, as I've told you, on audiometry also, if you perform, even if you perform an audiometry beta, on audiometry also, you will see that the patient's air conduction is going to be poor because the sound was not able to conduct via the external or middle ear, whereas the patient's bone conduction would be absolutely normal. And there will be a significant AB gap beta on the audiogram. AB gap matlab when there is a significant gap between both the lines, air conduction and bone conduction lines beta, that gap should be of more than 15 decibels. Then we say it is a significant AB gap. So these three features on a pure tone audiometry are classically suggestive of again a conductive hearing loss. Hopefully clear. तो याद रखना ये बात. अगर ये picture दिया हुआ है, it has to be a CHL or a conductive hearing loss. We know they have said that the patient is having a negative Rene. They have said that the patient is having a poor air conduction. So it has to be nothing else but a case of CHL or a conductive hearing loss. Matlab either the problem is in the patient's external ear or in the patient's middle ear beta. Next important, on examination they say a reddish mass was observed बच्चे, ठीक है, a reddish mass was observed behind the intact tympanic membrane beta. What will be the likely diagnosis? So we know the mass was observed behind the tympanic membrane beta. That means inside the middle ear बच्चे. Okay, so here you are able to see the orthoscopic picture. Whenever a person comes to you with some problem inside the ear beta, we generally do an investigation called as an otoscopy, on which we will be able to examine the external auditory canal and the tympanic membrane. Here behind an intact tympanic membrane, we are able to see this reddish mass, which looks like which sign beta? This reddish mass, which is growing from the floor of the middle ear beta. It is looking like a rising sun beta. So on audiometry, on otoscopy, you are able to see a classical rising sun sign beta. On otoscopy, we are able to see a classical rising sun sign. Hopefully clear. And we know beta pulsatile tinnitus, okay, as a complaint, and rising sun sign on otoscopy is a diagnostic feature of which condition, all of you? I hope all of you are quite aware. This is a diagnostic feature bache, in nothing else but option D, that is Glomus tympanicum beta. It is a diagnostic feature of a condition known as Glomus tympanicum. Ab, let's rule out the options one by one and then we will talk about Glomus tympanicum. If I say option A says chronic otitis media. Now we know otitis media means a middle ear infection beta. And whenever the person is going to have a middle ear infection bache, the patient is going to have earache, patient may have fever, patient may have conductive hearing loss beta. Yes, conductive hearing loss is mentioned over here beta, but earache, discharge, fever, these kind of features are not there, and there is no mass that can be observed in chronic otitis media usually. Okay. Next important beta, glue ear. If they ask you, definitely again glue ear mein there is collection of fluid inside the middle ear cavity beta. So here there was no fluid collection in the middle ear cavity, rather there was a reddish mass growing in the middle ear cavity. That's the reason why glue ear would be ruled out from the option. Option C says acoustic neuroma. I hope all of you are quite aware. Acoustic neuroma is a benign tumor arising from the 8th cranial nerve or the vestibulocochlear nerve. And we know as 8th cranial nerve will be damaged, the patient of acoustic neuroma will not have a conductive hearing loss. Rather, the patient will suffer from a SNHL, that is sensory neural hearing loss. And whenever the patient will have a sensory neural hearing loss beta, the Rene is not negative. Rene will be positive in a patient of sensory neural hearing loss. Second important, on the pure tone audiometry, not only the air conduction will be poor, but even the bone conduction is poor. So when air conduction and bone conduction both will be poor beta, that is a feature of SNHL or sensory neural hearing loss on a audiometry. Clear about? So that's the reason why acoustic neuroma is ruled out from the option. And any which way, I have always told you to remember this properly. Pulsatile tinnitus is the most important keyword. And another picture which was very classical was the rising sun sign beta. Okay? Yes. Now if I talk about Glomus tympanicum, it is another type is going to be Glomus jugulare beta. Now what is the basic difference between both the conditions? So yaad rakhna, the basic difference is the site of origin. We know that Glomus tympanicum we say beta when the tumor is actually going to originate from the middle ear cavity beta, from the promontory. So in the middle ear, whenever the tumor originates from the promontory, it is called as Glomus tympanicum because middle ear is known as tympanum. Glomus jugulare it will be called beta whenever it usually originates from the glomus cells around the jugular bulb. So whenever it originates from the glomus cells around the jugular bulb, it should be called as Glomus jugulare. We know that this actually is a vascular tumor beta, and as it is a highly vascular tumor, therefore it presents to you as a reddish mass beta in the ear. Second important, as it is vascular tumor, therefore the patient is able to hear those pulsations beta, and that's the reason there is a pulsatile tinnitus bache. Clear about? So these are the important points that you need to know. Now, whenever a person of Glomus tympanicum or Glomus jugulare will come to you, we know the initial complaint is always the patient having a conductive hearing loss beta. Along with that, the person will have a reddish mass behind the intact tympanic membrane. Okay, that will give us a rising sun sign. Third important, sometimes the mass will grow further beta, damaging the tympanic membrane, and then you will be able to find a reddish bleeding mass even growing inside the external auditory canal beta. Clear? And most important feature is pulsatile tinnitus. Hopefully clear. These are the symptoms. Now, whenever a patient of Glomus tympanicum or jugulare comes to you beta, there is one more sign that we can elicit, and that one more sign is called as the Brown sign. Now, on otoscopy, what we can do beta? We can definitely do a seagulization. Seagulization matlab putting pressure beta over the vascular mass bache with the help of a Siegel speculum. So whenever we will put pressure over this reddish vascular mass beta, it is going to turn pale in color. And whenever this reddish mass turns pale in color beta, that is known as Brown sign as well. And apart from that, if you see what is the investigation of choice, let me know once in the chat box. What is going to be the investigation of choice for a case of Glomus tympanicum or a Glomus jugulare? Very good. So we know beta that though it is going to be a tumor bache, the investigation of choice which is there beta, it is going to be a CCT scan. The investigation of choice has to be a CCT scan. And why not a biopsy? Reason is beta, we know that though it is a tumor, we don't go for a biopsy because it is highly vascular in nature. And as it is highly vascular in nature beta, that's the reason you have to remember that biopsy is going to be absolutely contraindicated. So we know biopsy is contraindicated in two ENT tumors beta. One condition is Glomus jugulare. Second condition is a juvenile nasopharyngeal angiofibroma. Two conditions where biopsy will be contraindicated beta in ENT. That has to be remembered. Next, when you do a CCT of this patient beta, you are able to see. Can you see this bone has got eroded or damaged beta? Okay. So the bony septum between the carotid canal and the jugular foramen is eroded bache, and therefore it is a likely case of what with sign? Phelps sign beta. So whenever this bony septum is going to be eroded bache, that is classically known as the Phelps sign bache. Okay, so CCT scan gives you the classical Phelps sign. And treatment, if they ask you now, let me know in the chat box what should be the treatment in a patient of Glomus jugulare or a Glomus tympanicum. Options are chemotherapy, radiotherapy, chemoradiation, or surgical excision. What should be the treatment in a patient who is having a Glomus jugulare or a Glomus tympanicum beta? The treatment of choice or the surgery of choice in patients of Glomus jugulare or Glomus tympanicum has to be very good bache. So we know that we have to mark it as surgical excision beta. So surgery or surgical excision has to be the best treatment. But we know beta that if in a case of a vascular tumor, if you directly try to approach for a surgical excision, then the vascular mass is going to bleed too much beta. So therefore, before the surgical excision beta, before going for a surgical excision, definitely please remember we have to go for a preoperative embolization beta. Okay, as we have discussed, definitely whenever we go for a surgical excision, before that we always have to embolize the main blood vessel beta, which is actually supplying this vascular tumor. That has to be carried out. Hopefully clear to all of you now. So that was all about your Glomus jugulare or Glomus tympanicum. Do remember that. Next is question number 2 beta. Another easy question which states we are having a 40-year-old patient bache who presents to us with complaints of extreme pain and hearing loss beta in their right ear. He also experiences beta pain during chewing. Along with that, examination reveals there is a tracheal sign which is positive beta. The tracheal sign in the patient is positive. What is tracheal sign? Whenever I press the tracheus beta, patient is going to experience pain. That is tracheal tenderness or tracheal sign. That is positive. Purulent ear discharge is going to be noted beta with obliteration of the retro-auricular groove beta. The retro-auricular groove which is there behind the pinna. Auricle means pinna. So behind the pinna, this groove which is there beta, that is not present due to the swelling maybe, right? As there would be a swelling, this retro-auricular groove which is there beta, it is absent or it is obliterated. What is the likely diagnosis of the case? Itna to clear hai by the features that you are able to see that the patient is having extreme pain. Along with that, the patient is also having pain during chewing beta, and the tracheal sign, that is tracheal tenderness, is positive. By all of this beta, I can say definitely it seems to be a case of an infection, which is right. It seems to be a case of an infection. Along with that, they have also said there's a purulent ear discharge, which almost confirms that yes, it is a case of an infection itself. and due to infection there will be inflammation. That's the reason beta the patient is having pain or the patient is having obliteration of that retroauricular groove due to swelling. Clear? It is which kind of an infection if they ask you? I hope all of you are quite aware. Now if I am going to say, okay, why it is option D or why it is localized otitis externa? Anybody, what is the reason for calling it as localized otitis externa, and why not otitis media? Why it could not be option A? Why it is only option D beta? So I hope all of you are quite aware that whenever a person will have an acute otitis media, that is an acute infection of the middle ear beta. So acute otitis media mein, please tell me beta, what is going to be the different feature? It is not a case of malignant otitis externa. Reason is malignant otitis externa mein the patient will be immunocompromised like an elderly diabetic patient usually, and in that condition the patient will have a blood stained ear discharge or the patient will have granulations inside the external auditory canal along with multiple cranial nerve palsies. Nothing of that is mentioned over here, so it cannot be a case of a malignant otitis externa. Hopefully clear. So please remember beta, the only reason to call it as otitis externa are these two which I've highlighted with green color beta. Okay, one thing is tracheal sign or tracheal tenderness. We know that whenever you press the tragus beta and the patient experiences pain, that tracheal tenderness is positive only in cases of otitis externa or an external ear infection. Clear? Second important, purulent ear discharge. When only pus is present inside the discharge beta, that is again a feature of otitis externa or an external ear infection. Why? Because in patients of acute otitis media beta, patient will surely have a conductive hearing loss. Okay, that will be a common feature. Patient will have a conductive hearing loss, but the tracheal sign or the tracheal tenderness will be negative. Okay, there is no pain on pressing the tragus beta. So tracheal sign is always negative in patients of acute otitis media. Okay, so that is important thing. Second important thing, that in patients of otitis media beta, I have told you already, patient does not have only a purulent ear discharge. Patient has a mucopurulent ear discharge. Why? Because whenever in a patient of otitis media beta there is an infection and the tympanic membrane gets ruptured, then the not only pus comes outside beta, but even the mucus of the middle ear is also going to come outside. And when the discharge contains mucus plus pus together, it is called as mucopurulent ear discharge. Hopefully you remember that. Okay? Yaad rakhna, otitis media or middle ear infections mein the tracheal sign or tracheal tenderness is negative and there is a mucopurulent ear discharge, not a purulent ear discharge. So that is the reason acute otitis media is out of choice. Second important option was B, that is otitis media with effusion. We know otitis media with effusion is another name for glue ear. Now we know in patients of glue ear bache, there is blockage at the level of the eustachian tube, due to which the middle ear is not able to drain the secretions. And as the middle ear is not able to drain the secretions, all these secretions keep on collecting inside the middle ear cavity, and that leads to basically a conductive hearing loss in the patient. So yes, the patient would have a conductive hearing loss in case of glue ear, but there is absolutely no pain beta in cases of glue ear or otitis media with effusion. Reason, please remember that in cases of glue ear beta, there is a sterile fluid which collects within the middle ear cavity. Okay, as there is no sterile fluid beta, no infection at all. Why the patient would have pain? Here too they are saying the patient is having extreme pain. So therefore it is not a case of glue ear beta, because it is glue ear is not an infection itself. And there is no discharge which happens in glue ear. Next important option C says beta, that is vestibular neuritis. We know vestibular neuritis is infection of the inner ear beta or the vestibule basically. But due to that, whenever there will be a vestibular neuritis, the patient's main complaint is going to be vertigo. Why? We know that vestibular organs which are there beta, like the utricle and saccule, they are mainly responsible for the linear balance of the patient. And the other structures beside them, that is the semicircular canals, they are responsible for the angular balance of the patient. So therefore, whenever there will be a vestibular neuritis in the patient will not have any kind of a purulent ear discharge beta. Okay? So vestibular neuritis means the person will have no discharge as such. Okay? Here also there was no discharge. Whereas apart from that beta, the person will also have, okay, the person will also have basically not a case of a conductive hearing loss, but rather there will be a sensory neural hearing loss. And third important beta, that the patient's tracheal sign will be obviously negative. Okay? So whether it is glue ear or it is a case of vestibular neuritis, in both these conditions beta, the tracheal sign of the patient is obviously negative. Okay? So obviously by ruling out all these options, you can easily come to a conclusion beta that this is a classical case of option D, that is nothing else but localized otitis externa beta. And I've told you keywords for localized otitis externa are nothing else but one is a tracheal sign positive, that is tracheal tenderness present, and second definitely a purulent ear discharge. Clear about? So this has to be a clear cut idea. So this is the classical picture beta of a localized otitis externa. I hope all of you are quite aware that localized otitis externa means infection of hair follicle inside the external ear. So whenever there's infection of hair follicle in the external ear, that is called as a furuncle. Okay, and that condition will be called as furunculosis. So we know localized otitis externa is also called as furunculosis beta, and here there is an infection of the hair follicle along with the surrounding skin bache, and due to that the patient will have extreme pain inside the ear. Along with that, the patient may have a tracheal tenderness. Along with that, whenever definitely this abscess ruptures, the patient would definitely have a purulent kind of a ear discharge. These are the usual features in patients of localized otitis externa or furunculosis. If they ask you in these conditions, what should be the treatment? We know for localized otitis externa, the treatment is, we know the most common cause of this condition is Staph aureus beta. The most common cause of localized otitis externa or furunculosis is always Staph aureus, and as Staph aureus is going to be the commonest cause, that's the reason why we have to go for what? Antibiotics. So obviously we have to go for antibiotics beta, and we should go for topical antibiotics or antibiotic eardrops beta. So you can give ciprofloxacin like eardrops. Along with that, the second thing that I should do is a IG packing. Now when I say IG packing, what is IG packing? Icthymamol glycerine packing beta. The treatment has to be beta IG packing, that is an icthymamol glycerine packing, which helps in reducing the inflammation inside the external auditory canal. Hopefully clear to all of you now. So that is important to be remembered about a case of localized otitis externa or a case of furunculosis. Clear? This is the picture beta where the person would be either an elderly patient or the person will be a known diabetic. Okay? So either the person is elderly or the patient is suffering from diabetes mellitus, or the patient is basically taking high doses of corticosteroid. Matlab, eventually I would say the person is immunocompromised. Okay? So there was an immunocompromised patient who comes to us with complaints of what? First of all, the person is having a CHL, that is a conductive hearing loss. Second important beta, in this patient definitely the patient will have a purulent ear discharge. Okay, there will be a pus like ear discharge, pus containing ear discharge beta, purulent ear discharge. But the importance will be beta in this patient, whenever there is a purulent ear discharge, it may be blood stain bache. So there will be a blood stain purulent ear discharge beta which will be seen. Apart from that, this patient will also come to you beta with multiple cranial nerve palsies. This patient will come to you with multiple cranial nerve palsies. Here also, if you examine beta, the patient's tracheal sign will be positive. Okay, here also the person's tracheal sign will be positive. Bolo, what is the likely diagnosis that you think in this condition? This condition that I have just now described in this patient beta, you can see there is an elderly, diabetic or any immunocompromised patient coming to you with complaints like conductive hearing loss, purulent ear discharge which is blood stained in nature, tracheal sign or tracheal tenderness is positive, and cranial nerve palsies can be there beta. Okay, cranial nerve palsies can be present or absent. Okay, and here if you observe the external auditory canal of the patient beta, on performing otoscopy of the external auditory canal, you will find that the patient is actually having what? Granulations inside the external auditory canal. The patient is having granulations inside the external auditory canal beta. Yes, so if these are the features beta, then it is a classical case of nothing else but malignant otitis externa. Then it is a classical case of a malignant otitis externa. Let me know in the chat box, what is the most common cause of malignant otitis externa? What is the most common or the leading cause of a case of a malignant otitis externa beta? Malignant otitis externa ka most common cause would be, we know malignant otitis externa beta is a deadly condition, and therefore here the most common cause, if they ask you, has to be a dangerous bacteria, and that dangerous bacteria beta which can cause malignant otitis externa is nothing else but Pseudomonas bache. Yes, so it is Pseudomonas definitely which is the most common cause of malignant otitis externa bache. And therefore if they ask you what should be the treatment, so we know that the treatment in patients of malignant otitis externa, as it is a bacterial infection, treatment has to be antibiotics. The only difference is, okay, we know that all antibiotics are not effective against Pseudomonas. That's the reason we have to give broad spectrum antibiotics or anti-Pseudomonal antibiotics to the patient beta, and they should be usually given via an injectable route. Okay, they should be given via injectable route. So IV antibiotics should be given in the patient of malignant otitis externa. Let me know, last question about malignant otitis externa, that which is going to be the most common cranial nerve paralysis in patients of malignant otitis externa. Yes, antibiotics में you can give third generation cephalosporins like ceftriaxone. Please tell me basically beta, the most common cranial nerve that is paralyzed which in patients who are suffering from a malignant otitis externa. Answer would be very good. So the most common cranial nerve that is paralyzed within these patients of malignant otitis externa is going to be the seventh cranial nerve. Reason, we know beta that the patient is having otitis externa, that is the external ear infection, and we know seventh cranial nerve is very close to the external ear beta. So the seventh cranial nerve, the facial nerve, is the most common cranial nerve paralyzed which. Then when the infection spreads to the skull base beta, causing a skull base osteomyelitis, then the nerves which are exiting from the skull base beta, those nerves can also get involved, like the 9th, 10th, 11th cranial nerves as well. Clear? Chal. Next is another common question from surgery and from ENT beta, which is very important. Question 3. It states beta, a child has been brought to you by the mother to an emergency which with complaint of foreign body ingestion. So it is a case of a foreign body ingestion which they are saying that the child is asymptomatic as of now and the x-ray done which has been given below. What is the most important step in the management of this child beta? What is the most important step in the management of this child? Now here definitely you are able to see this, and this is the picture beta. Okay? This is the picture that you are able to see. Now if they ask you what should be the answer, we know whenever a patient comes to us with foreign body ingestion beta, yaad rakhna, most of the cases are usually children itself, right? The most common age group who is going to have a foreign body ingestion will be children. And whenever I say beta that children may, what is the most common type of foreign body? If they ask you what is the most common type of foreign bodies in children which, so we know it is usually a case of coins. Okay? So most of the times beta, the most common foreign body ingested is coins. Sometimes it can be peanuts also. So coins, peanuts, these are the commonest foreign bodies which are ingested by children. Next important, if they ask you beta that which is the most common foreign body in adults. The most common foreign body in adults, definitely if they ask you beta, then it is nothing else but fish bone beta. We know fish bone is the most common foreign body ingested by adults. And if they ask you which is the most common foreign body ingested by elderly patients, the elderly patients में the most common foreign body ingested will be the loose teeth or the dentures. So loose teeth or dentures is the most common foreign body ingested by children beta. No, sorry, by elderly patients beta. Hopefully clear to all of you now. So that is about foreign body ingestion which. Now we know that whenever a person comes to us with foreign body ingestion, okay, please remember the person is going to be completely asymptomatic or the patient may have symptoms. Now whenever the person will have symptoms beta, those symptoms will be like the patient will come to you in the emergency like this. This is the classical presentation that is called as choking sensation beta. So either the person is having choking sensation, the person may have difficulty in breathing beta called as dyspnea, or the patient may have difficulty in swallowing beta called as dysphagia. So choking, dyspnea, dysphagia, stridor, these are the common features beta whenever a person is going to have a foreign body ingestion. Now whenever these are the cases beta, obviously whether the child is symptomatic or asymptomatic does not matter. We have to move on to investigations beta. And the first line investigation that we will always do, the first investigation beta that we will always do in a case is always an X-ray. The first line investigation is always an X-ray beta. If I talk about the X-ray beta, this X-ray is going to appear like this. We have to take the X-ray in two views which first is going to be the AP view, that is anteroposterior view, and second is the lateral view beta. Now whenever I take the X-ray in two views beta, one is the AP view, second is the lateral view, then you have to understand based on the location, based on the appearance of the foreign body beta, I can say that in which structure the foreign body is actually present. Matlab, whether the foreign body is present in the airway, that is trachea, or whether the foreign body is present inside the esophagus beta. How? Understand. We know which is that, please remember, the anteroposterior or the AP diameter of your trachea is more. That's the reason whenever the foreign body goes into the trachea beta, it appears like this. Matlab, on AP view beta, the foreign body is going to appear slit like, whereas on lateral view bache, the foreign body is going to appear circular. Clear? Whereas if I talk about bache, the transverse or the horizontal diameter of your esophagus is more. Therefore, whenever a person's foreign body goes inside the esophagus beta, then on the AP view it is going to appear circular beta, and on the lateral view it is going to appear slit like bache. Hopefully clear to all of you now. So that is what is important to be remembered. याद रखना, यहाँ पे you are able to see the first picture that on the anteroposterior view the foreign body is appearing slit like बच्चे, whereas on the lateral view the foreign body is appearing circular, and we know whenever the foreign body appears slit like on the AP view and circular on the lateral view, the foreign body has to be present inside the airway, that is trachea. Whereas if I talk about this one, here you can see on the AP view the foreign body appears circular beta. On the AP view foreign body appears circular, and on the lateral view it is appearing slit like. And we know whenever the foreign body appears circular on the AP view and slit like on the lateral view, matlab it has to be present inside the GI tract, that is the esophagus beta. Clear about? Now if they ask you about the treatment, I hope all of you are quite aware about the treatment. First of all, if the foreign body is anywhere inside the airway, when I say anywhere in the airway beta, whether it is in the larynx or it is present inside the trachea or it is present inside the bronchi beta, what should be the treatment? Let me know in the chat box. If the foreign body is anywhere in the airway beta, larynx, trachea or bronchi, can we keep the foreign body inside the airway? Will we allow the foreign body to be present inside the airway? Obviously not, right? We will never allow the foreign body to be present inside the airway beta. We should always go for removal of the foreign body if it is present inside the airway, irrespective of the location. Wherever it is present inside the airway beta, the treatment is always an endoscopic removal. हमें पता है, wherever is the foreign body in the airway of the patient beta, the treatment is always an endoscopic removal. Hopefully clear to all of you now. That is important. Next important, if they ask you beta, is if the foreign body is inside the esophagus. So I hope all of you are quite aware, whenever the foreign body is in the esophagus beta, then we have to first of all check the location. Depending on the location, we will decide the next step in the management. If there is the esophageal foreign body, if the foreign body is in the esophagus beta, if the foreign body is located above C6, which if the foreign body is located above C6, so we know what is at the level of C6. At the level of C6 beta, we have something called as the CPS. What is CPS? Cricopharyngeal sphincter. Now we know that cricopharyngeal sphincter, or this upper esophageal sphincter beta, it is the narrowest portion of the whole GIT. Now if the foreign body is present above C6 bache, or above the CPS, that means the foreign body is large in size bache, that's the reason it is not able to cross the C6 or the cricopharyngeal sphincter. So as it is not able to cross the cricopharyngeal sphincter beta, if it is above C6, then the management is always an endoscopic removal, that is an esophagoscopic removal, you can say. Okay? Above C6, the management is always removal. But second condition, when I say there is a esophageal foreign body which is located below C6, that is below the cricopharyngeal sphincter. Now whenever the foreign body is present below the C6 or below the cricopharyngeal sphincter, that means the foreign body is very small in size. Why would I say that? Reason, if it is able to cross the narrowest portion of the GIT beta, that is the cricopharyngeal sphincter, we know it is very small in size. And if it was able to cross the narrowest portion, that is CPS, obviously we know it will be able to cross the whole GIT easily beta without any problem. So what should be the treatment? Whenever a person has a foreign body in the esophagus, but that is present below the C6 beta or below the cricopharyngeal sphincter. So what should be the treatment? It has to be nothing else but observation beta, that is wait and watch, you can say. The treatment is nothing else but observation, and at that time beta we will keep on doing serial x-rays which okay, observation has to be done along with serial x-rays. Clear about? So observation along with serial x-rays have to be done beta, that you have to keep in mind. Reason, the foreign body is below the C6, so you will just ask the parents beta to give meshy food to the child. Meshy food means something like okra, that is bhindi, or dalia, okay, or jellies, bananas. So these will ensure beta that the foreign body passes easily from the esophagus or through a GI tract beta, and then it comes out in the child's stools beta. That is what is important. Clear about? So now when you repeat the serial x-rays beta after every 24 to 48 hours, if you see that the foreign body is distally moving bache, and the patient is also asymptomatic, you can continue observation in that patient. But in the serial x-rays, if you are able to see that the foreign body has got blocked beta, the foreign body definitely is not able to move properly bache, and the patient is turning symptomatic, he is having abdominal pain for example, then in those conditions beta, we have to get the foreign body removed by an endoscopic removal irrespective of the location. So whenever the child turns symptomatic, or whenever the foreign body is not moving on the serial x-rays, then you can definitely go for an endoscopic removal beta. That is important to remember. No issues with this. Now coming to the question, basically beta, here there is a question which says, ab mujhe batao answer. Okay, first of all tell me the location of the foreign body, whether it is in the trachea or the esophagus beta. what is the location of the foreign body, whether it is in the trachea or the esophagus. Here it is an X-ray AP view, that is an anteroposterior view given to us, and on the AP view or the anteroposterior view, beta, the foreign body is appearing circular. So on the AP view, whenever the foreign body appears circular, I hope all of you are quite aware, it is in the trachea or esophagus. Whenever on AP view the foreign body appears circular, that means surely the foreign body is inside the esophagus, beta. Very good. So whenever it is appearing circular on AP view, it has to be inside the esophagus, beta. Okay. Now please tell me whether it is above C6 or below C6. Now in practice, I have told you, beta, that we tend to count the number of the cervical vertebrae on the X-ray. But in your examination, you will not be able to count the number of cervical vertebrae. Therefore, what should be used as a landmark, beta? So obviously, to see whether the esophageal foreign body is above C6 or below C6, you always have to use the clavicle as the reference point, bache. That means, if definitely, beta, the clavicle which is the, if the foreign body is above the clavicle, matlab it would be usually above the C6, beta. But if the foreign body is touching any part of the clavicle, if the foreign body touches any part of the clavicle or the foreign body is below the clavicle, that means it has surely crossed the C6 or the cricopharyngeal sphincter. Why? We know, beta, clavicle is over here. So if the foreign body is touching any part of clavicle, it has already crossed C6 because C6 is at this level, beta. Can you see? So that is what is important. So यहाँ पे definitely, beta, you can see the foreign body is going to be below the clavicle, beta. And if the foreign body is below the clavicle, I have told you, it is always below C6, beta. The foreign body, whenever it is below clavicle, beta, it is going to be always below C6. Closely observe the X-ray, but do remember that. Closely observe this X-ray that I have given you. And now definitely answer, beta. Okay? Hopefully you have observed the X-ray clearly. Now answer me what should be the answer to this question. Bolo. Now answer what should be, now answer in the chat box. What should we answer, or what would be your answer in this case? Meshy food is not the first line management. Take the first thing. Meshy food is given alongside. That's the reason I've told you to see the X-ray clearly. That's the reason I've told you. See the X-ray clearly. 4 बार बोला मैंने. What is observed on the X-ray? You're not only able to see a circular shadow, na? You're not only able to see a circular shadow. Yes, etc. What is seen? Here you are able to see, beta, that there is not one border, but there are two borders basically, one inside another. And whenever there are two borders basically, beta, it is a double border. So double border or double ring which is seen. So we know, beta, whenever there is a double border or double ring which is seen, beta, on the X-ray, it has to be nothing else but what? Double ring on an AP view or a beveling on the lateral view. The double ring on an AP view, beta, or beveling on the lateral view has to be a case of which type of foreign body, beta? It has to be a case of what? A disc battery or a button battery, beta. Okay? So please remember, it is left side. Okay? So please remember, double ring or beveling is seen, bache, and that is nothing else but a disc battery. Okay? Please remember, that is nothing else but, beta, a disc battery or a button battery. And if I talk about a disc battery or a button battery, beta, I hope all of you are quite aware that whenever there is a disc or a button battery, beta, irrespective of the location, whether it is in the airway or it is in the esophagus, whether it is in the whether it is above C6, below C6, whatever it is, we know that definitely you have to go for an endoscopic removal. You have to go for an endoscopic removal. They have not mentioned any timeline. They have not said for 8 hours the child is asymptomatic. Okay? So don't go with the question that I've told you earlier. Okay? So yaad rakhna, definitely. They have not mentioned any timeline. So we know that disc battery or a button battery, if it is present, beta, irrespective of the location of the foreign body, the treatment should always be an endoscopic removal, an urgent or immediate endoscopic removal. Now what should be the answer to this question? The answer to this question should be A, B, C or D. Bolo now. Hopefully now it is clear. Now the answer to this question, I hope that's very clear to all of you. It is nothing else but option A, beta. As the foreign body is inside the esophagus, so we have to go for an endoscopic, that is an esophagoscopic removal. Clear about? We know if the foreign would have been in the trachea, beta, then we should go for tracheoscopic removal. But In cases of trachea beta, on AP view the foreign body will not appear circular. On AP view the foreign body should appear slit like. Next, observation and x-rays. Yes, observation and x-rays would have been done beta in this case if it was not a case of a disk battery or a button battery. If it was just a case of a coin beta, simple coin, then I would have gone for observation and ciliary x-rays. But coin agar hota to then there would only be a single ring which will be seen on x-ray. Here there is a double ring seen, so it has to be a case of disk battery beta. Okay? So that is important to remember. Meshy foods are given as an adjunct basically beta, usually whenever we keep the child under observation. Clear about? So that is what is important to remember. Understood? Chalo. Next important is this. What is this manure that is performed? Here the person was having meal beta, an alcoholic person for example, he was intoxicated with an alcohol, beta, now having meal beta. Okay? So alcoholic person having meal and suddenly starts getting a choking sensation beta. Alcoholic person having meal starts getting a choking sensation, which what has happened? We know in this alcoholic patient beta, as the airway reflexes or the cough reflexes would have been diminished, therefore the person might have aspirated the food material and the food material would have gone inside the patient's airway, and whenever the food material goes and blocks the patient's airway, all of a sudden the patient starts getting this choking sensation along with dyspnea, stridor, these kind of features beta. So in those conditions, when you're out of the hospital, not inside the hospital, when you're outside the hospital beta usually, then you can actually stand behind the patient beta. You can definitely hold over the patient's abdomen, over the epigastrium, and you can give upward and backward thrust beta. Upward and backward direction mein bache, you should give pressure, so that definitely the pressure inside his airway increases and the foreign body is thrown out beta. That is what is important to remember. Clear? So Hemlick's, this is known as the Hemlick's manure bache. So we know that Hemlick's manure can be done when the patient is actually having a choking sensation and it is a emergency beta, but usually outside hospital, because inside hospital beta we can go for an endoscopic removal. In case if the endoscopic removal would take time, then you can go for an Hemlick's manure. Okay? The Hemlick's manure is done in cases of emergency when the person is having a choking sensation or a very severe respiratory distress beta. Clear? So that is what is important. It is in the epigastrium, always above the umbilicus. Epigastrium mein karna hai, not on the umbilicus. Clear? And I hope all of you are quite aware that Hemlick's manure is not done beta usually. Okay? So Hemlick's manure is not done in patients who are pregnant beta. In pregnant females, you should not go for Hemlick's manure, or it is not even done beta in children who are usually less than 2 years of age. In children who are less than 2 years of age beta, we don't tend to perform Hemlick's manure. Hopefully clear? Sure. Next important, if I talk about question number 4 beta, it states, this was a very easy question. If you know even one thing, you are able to solve the question beta. Okay, just by looking at the options also. A 32-year-old female bache presents to you with complaints of progressive bilateral hearing loss beta, which is more in the right ear. Matlab, there is more worsening beta of the right ear. The hearing loss is more severe in the right ear beta. Okay, so that is what is important to be remembered. Okay. Next important, they are saying that after the initial evaluation, a stepedotomy of the right ear was planned. I hope all of you are quite aware beta that stepedotomy, if they are saying, that means it is opening up the stapes beta. Matlab, we know sometimes what happens, there is fibrosis around the foot plate of stapes, due to which the stapes gets fixed beta and it is not able to move at all. Okay, that condition is known as otosclerosis. So whenever in a young female beta who comes to us with otosclerosis, we know as the stapes has got fixed, we have to remove that fibrotic material and we have to make the stapes free beta. That procedure or that surgery is known as stepedotomy. Okay, so here the stepedotomy of right ear was planned. Matlab, yes, we know that right ear is having more severe hearing loss. Why? Because the patient came to us with bilateral hearing loss, na? But we know that more severe case is in the right ear beta. What might have been the results of tuning fork test beta conducted in this patient, they are asking you. Now, I hope all of you are quite aware that here they have said person has been planned for a stepedotomy. If the person has been planned for stepedotomy, so it is a case of otosclerosis. Now, whenever I talk about otosclerosis, itna to I hope all of you are clear about that otosclerosis is nothing else but fixation of stapes beta. Here there is fibrosis around the footplate of stapes that leads to fixation of stapes. And when stapes will get fixed beta, stapes will not be able to perform the piston-like action. So obviously what will happen? The vibrations of the sounds from middle ear will not be conducted into the inner ear of the cochlea beta. And that's the reason, as the sounds are not conducted. So in patients of otosclerosis, the patient will have a Bilateral conductive hearing loss. Patients of otosclerosis are young females beta coming to you with mainly complaint of a gradually progressive bilateral conductive hearing loss. Okay? That is important to be remembered beta. And we know here it is a case of conductive hearing loss. I hope all of you are quite aware. Whenever there is a conductive hearing loss, I have told you one thing, that what will be the finding on a tuning fork test or what will be the finding on Rene beta that we have discussed. Let's come back to it after discussing the tuning fork test results. Now if I talk about bache tuning fork test, whenever a person comes to you us beta with complaints of hearing loss, whenever a person comes to us bache with complaints of hearing loss, we have to perform a tuning fork test in that patient beta. Clear? Now whenever we tend to perform a tuning fork test, please tell me the most common frequency of tuning fork that we use for this test would be. That was a PYQ. The most common frequency of tuning fork that we use for this test is going to be. The most common frequency of tuning fork that we use for this test is going to be, anybody? 512 hertz beta. So it is going to be a 512 hertz ka tuning fork that is most commonly used for a tuning fork test. That is what is important. Now we know the speciality of tuning fork is that whenever you are going to strike the tuning fork beta, it is going to vibrate and it is going to produce vibrations beta, and those vibrations definitely okay will be heard as sounds. Important is now, first of all, we are going to check for two tests beta in a tuning fork test. Okay, first is I will keep the vibrating tuning fork beta in the front of patient's ear. Whenever I keep the vibrating tuning fork in front of patient's ear beta, that means the vibrations have to travel via the patient's external ear, then the middle ear, then the inner ear beta. So therefore this is what is called as air conduction beta, and here I am going to check for the complete ear of the patient, external, middle as well as the inner ear beta. Okay, so one test that I will do is called as air conduction. Second important beta, again I will strike the tuning fork and I'll keep this vibrating tuning fork, this time over the patient's mastoid bone. When I keep the vibrating tuning fork over the patient's mastoid bone beta, these vibrations will directly reach to the inner ear of the cochlea beta via the mastoid bone. Now when the vibrations are going to reach to the inner ear of the cochlea of the patient's beta, obviously we are only going to check for the inner ear of the cochlea of the patient. Okay, and here as the vibrations are traveling by the mastoid bone, we call it as bone conduction. Air conduction is a complete test of hearing. Okay, it will tell us about the problems in external, middle or inner ear, but bone conduction is only a partial test of hearing because here the vibrations directly go only to the inner ear or cochlea. So it will tell us about the problems of only the inner ear beta. Hopefully clear. Now if they ask you, first test is what? I will make the person hear air conduction as well as bone conduction, and after that I'll ask my patient to compare that which sound was better, and this test is called as Rene beta. This test is classically known as Rene test bache. So Rene test may just ask your patient beta to compare between the air and bone conduction. The first one, if they say beta person is having a the person is a normal patient beta. So for example, if the person is having normal hearing, so what is going to happen? Obviously when you ask him to compare between air and bone conduction, he'll say, Dr. Saab, the air conduction was quite better. Why? We know in air conduction the sound has to travel via external and middle ear beta, which only contains air, and we know whenever the vibrations of sound will travel via air medium, there will be less resistance beta because molecules in air are far away from each other. But if I talk about when we check for bone conduction, bone is a solid medium where the molecules are very compactly arranged beta, and therefore the bone will provide more resistance, and that resistance is going to cause diminution of sound beta, and due to that the bone conduction of the patient is going to get diminished. So easily in a normal person, whenever you check air and bone conduction, the air conduction is always heard better as compared to bone conduction. And we know that whenever air conduction will always be better than bone conduction beta, okay, that is basically called as a positive Rene. Whenever air conduction is better than bone conduction, it is called as a positive Rene. Second is a case of SNHL, that is a sensory neural hearing loss. Now whenever I talk about SNHL or a sensory neural hearing loss beta, that means what is going to happen? Understand, sensory neural hearing loss matlab either the patient's cochlea and the inner ear is damaged, or the patient's 8th cranial nerve, that is vestibular cochlear nerve, is damaged. So inner ear or the 8th nerve is damaged beta, that is SNHL or sensory neural hearing loss. Now in this patient beta, when you check for air conduction, that will be normal or poor. We know in cases of SNHL the air conduction will be poor. You will be like, sir, why? Reason, the sounds will easily travel via the external and middle ears, but ultimately they will get processed at the level of cochlea. And in a patient of SNHL, we know the cochlea or the inner ear has been damaged. That's the reason beta, the air conduction will not be processed properly and the patient will have a poor air conduction. Second, if I talk about basically beta, bone conduction. Here also the vibrations of sound will directly reach to the inner ear of the cochlea. But the problem is, again, the inner ear has been damaged. That's the reason. Even these sounds will not be processed beta, and therefore the person will have a poor bone conduction also. So we know in a case of SNHL or sensory neural hearing loss, both of them are poor beta. But still if you ask him to compare, he will say, Dr. Saab, air conduction was slightly better. Same normal funda applies beta, that air medium there is lesser resistance. So in a patient of SNHL, we know air conduction is also poor, bone conduction is also poor. But still he says that air conduction was slightly better as compared to bone conduction. And we know whenever air conduction will be slightly better compared to bone conduction, it has to be a positive Rene. So even in patients who are suffering from SNHL or sensory neural hearing loss, there will be a positive Rene beta. So yaad rakhna, by Rene, I cannot differentiate between a normal person and a sensory neural hearing loss. But I can easily pick up a case of CHL or conductive hearing loss. How? We know beta, if I talk about a patient of CHL or conductive hearing loss, matlab, here there is problem in conduction of sound, and conduction of sound is mainly done by the external ear and the middle ear. So whenever there will be a problem in the external or middle ear of the person, the patient will suffer from a CHL, that is conductive hearing loss. Now understand, whenever the person is having conductive hearing loss and you check his air conduction, the person's air conduction will be poor. Reason is, we know for air conduction the sound has to travel by the external and middle ear, and in a patient of CHL beta, the external or middle ear will be damaged. That's the reason definitely the patient's air conduction, when you check, it is obviously going to be poor. But when you check for his bone conduction, it comes out to be absolutely normal. Why? The person is only having a conductive hearing loss. So the problem is only limited to his external or middle ear. There is no problem in his inner ear or cochlea. So when you check for bone conduction beta, the sound directly reaches to his cochlea, which is absolutely normal. And that's the reason the person's bone conduction will be normal. So here air conduction is poor and bone conduction is normal. And as so if you ask to compare, he will say definitely bone conduction is slightly better. Why? Because obviously we know beta bone conduction was normal and air conduction was poor. Isliye he says that the bone conduction was better. And whenever bone conduction is better than air conduction, it is opposite. So it is called as a negative Rene. And yaad rakhna, whenever there will be a negative Rene beta, it has to be a case of CHL, that is conductive hearing loss. That is a direct hint. Clear? Second, if I talk about bache, is nothing else but Weber. Now what is done in Weber? Understand. Weber mein beta, I actually keep the vibrating tuning fork beta in the patient's center of the forehead. Okay? I'll keep the vibrating tuning fork bache in center of the forehead. Now whenever I keep the vibrating tuning fork in center of the forehead beta, the sounds will travel via bone conduction bache to both the ears. Now whenever I'm keeping the vibrating tuning fork in center of the ear and the person who is there beta, he's having a normal hearing. So what will happen? Equal vibrations will go to my right ear and equal vibrations will go to my left ear beta. Both the side ka cochlea is absolutely normal. So in both the sides there is almost equal hearing beta. In both the sides there is an equal bone conduction. And that's the reason beta the person perceives as if the sound is coming from somewhere in the center beta. So if the person is having a normal hearing, he says that Dr. Saab, the sound is coming from center of the forehead. So whenever a person feels as if the sound is coming from center of the forehead, that means basically beta the person is having a normal hearing, because in both the sides there is equal bone conduction. Clear about? Next, if I talk about a case of SNHL, that is sensory neural hearing loss beta. Now if I talk about SNHL or sensory neural hearing loss, understand what is going to happen over here. In this conduction beta, in this condition, for example, let's say my patient is having a sensory neural hearing loss in his right ear. Matlab, his right sided inner ear or cochlea is completely damaged. So whenever I check the Weber in this patient beta and I keep the vibrating tuning fork in the center of his forehead, what will happen? Equal vibrations will reach via bone conduction to both the cochlea. But the problem is, in the left side the cochlea is absolutely normal. So here the bone conduction is also normal. Problem is on the right side. As the right sided cochlea is completely damaged beta, therefore these sounds are not able to process on the right side bache. Okay? So here there is a poor bone conduction. So in a person suffering from SNHL or sensory neural hearing loss, whenever you ask him that you were able to hear the sound better in which ear, now the person will say, I was able to hear the sound better in my left ear. That means in the normal ear or the better ear beta, right? Because here the cochlea was damaged. So easily in a person of SNHL or sensory neural hearing loss, you see beta that the Weber is going to be lateralized to which ear? The Weber is basically lateralized to the better ear. Okay, because in the affected ear or the poor ear, the cochlea has been damaged, so there is a very poor bone conduction. Therefore, the Weber is better heard, or the Weber is lateralized to the better ear in a case of SNHL or sensorineural hearing loss. Next important, if I say beta, now this time my patient is having a conductive hearing loss in the right ear. Let's say, okay, conductive hearing loss in right ear, matlab the person is actually going to have beta problem in the external or the middle part of the right ear. Now I'm checking again for the Weber, so I'll keep the vibrating tuning fork in the center of the forehead. Now please remember beta, here also equal vibrations are going to both the ear, the normal left-sided ear and the affected right-sided ear beta. But this time when you ask that the sound is better heard in which ear or the Weber is lateralized to which ear, surprisingly beta, the person says that I'm able to hear this sound better in my affected ear or the poor ear, because the patient is suffering from conductive hearing loss. You'll be like, so why? Reason, we know beta, see, the sounds are traveling by bone conduction to both the ears equally. We know on both the sides the cochlea is absolutely normal. Why? Reason is beta, it is a case of CHL, so cochlea mein koi dikkat nahi hai. That's the reason in both the side beta the cochlea is absolutely normal. So cochlea is able to process the sound in the left normal ear also and the right affected ear also beta. So then how the Weber was lateralized? Reason was, we know beta that in the normal ear the air conduction was also normal, and that's the reason beta the external disturbances or the external sounds has led to diminution of this bone conduction. मतलब ये जो बाहर के disturbances है उसकी वजह से ये काम sound थोड़ा कम सुनाई दे रहा है in my normal ear. Clear है बात? याद रखना, due to the normal air conduction in my left ear beta, obviously the external disturbances were also heard, and that led to diminution of this bone conduction. But in my right ear, basically, we know that in the right ear, definitely, you are able to see beta that the person was having a conductive hearing loss. So there was a poor air conduction. And as in the affected ear or the poor ear, there was a poor air conduction beta. So the external noises or the external disturbances did not affect. And therefore, I was able to clearly hear this bone conduction. Okay, as the external disturbances could not diminish the sound beta due to a poor air conduction, I was able to hear this bone conduction very properly, and that is the reason the person says in a patient of CHL or conductive hearing loss, the sound was better heard beta in the affected ear or in the poor ear. So whenever the sound is heard better in the poor ear or the affected ear beta, that is the classical case of conductive hearing loss. That is what is important. Okay, so that is important to be remembered again. Next important, if they ask you beta, so yaad rakhna, whenever Rene is negative and the Weber is lateralized to poor ear, that has to be a case of conductive hearing loss. Whenever they say that the Rene is positive along with Weber lateralized to better ear beta, that has to be a case of sensorineural hearing loss. Hopefully clear. Now the third one you can do further beta if you want, that is absolute bone conduction. Now absolute bone conduction mein what we do? We check for bone conduction, but this time we close the patient's tragus beta. Why? So as you keep the patient's tragus closed, the external noises or the external disturbances are not going to affect anything. Clear? So therefore definitely beta, we have to close the patient's tragus and then we will check for bone conduction. Therefore it is called as absolute bone conduction. If the person will have a normal hearing, the patient's absolute bone conduction values will be equal to that of an examiner. If a person has normal hearing, the person's absolute bone conduction values are equal to that of examiner. If the person is having sensorineural hearing loss, obviously as the cochlea of the patient has been damaged, therefore the patient will have a very poor bone conduction over here. So the person will have a very poor absolute bone conduction beta. Absolute bone conduction of the patient is very, very poor if the person is suffering from a sensorineural hearing loss. But if I talk about CHL beta, that is conductive hearing loss, तो याद रखना CHL or conductive hearing loss के cases में there is no problem in the cochlea, and as there is no problem in the cochlea, the bone conduction is absolutely normal. That's the reason beta there is a normal bone conduction, you can say, or the value of the person will be equal to that of an examiner. Hopefully clear to all of you now. So just remember these three things. Clear. Now if I talk about this condition, bolo, we know that the patient is suffering from otosclerosis, and whenever a person is suffering from otosclerosis, he is going to suffer from a conductive hearing loss because the problem of otosclerosis is in the patient's middle ear beta. So it is a case of conductive hearing loss. Whenever there is a conductive hearing loss, what should be your answer? We know beta, whenever there is a conductive hearing loss, itna to clear hai that bone conduction should always be better than air conduction. Matlab, the Rene of the patient should always be negative. There is only one option bache with the Rene negative, and that is nothing else but option A beta. So we know that answer has to be option A. That is a bilaterally the Rene should be negative. Okay, it was very easy, just by Rene you would have come to the diagnosis. But still, if you want to go further, if there was another option with Rene negative, then you have to look at the second part, and that second part is Weber is lateralized to right ear. We know beta, which is the ear that is more affected. You can see there is a bilateral hearing loss, but the hearing loss was more beta in the right ear, therefore surgery was planned in the right ear. Matlab, the poor ear which is there beta, it is going to be the right ear. The poor ear which is there, which it is nothing else but the right ear. And whenever the Weber is lateralized to the poor ear beta, whenever the Weber is lateralized to the poor ear, we know it is a case of a CHL, that is conductive hearing loss beta. Hopefully clear to all of you now. So that's the reason that you have to remember these parts. Clear? Next is question number 5, bache. Another very common and a sarkari question of your exam. Just like juvenile nasopharyngeal angiofibroma, this is another common question beta, which could come in your examination. Here we are having a 58-year-old male bache who presents to you with persistent fullness of the left ear beta for a span of almost 3 months. And the patient also experiences hearing loss. On examination, there is fluid behind an intact tympanic membrane. We know whenever there is fluid collected behind the tympanic membrane, that means there is fluid collected in the middle ear cavity beta. So we know it has to be nothing else but a case of what? It has to be nothing else but, it has to be nothing else but beta, a classical case of glue ear. I hope all of you are quite aware now, right? It has to be a classical case of glue ear beta or a serous otitis media. Why? Because we know the condition that is known as glue ear or a serous otitis media. What happens in this condition? In this condition beta, the eustachian tube is blocked. And if the eustachian tube is blocked, what will be the problem then? To understand now, we know which is that eustachian tube is a connection between the nasopharynx and the eustachian tube. Yes. So eustachian tube, we know beta, it is a connection between the nasopharynx and the middle ear cavity. So whenever the eustachian tube in the of the patient in the nasopharynx gets blocked beta, so we know that the middle ear will not be able to drain the secretions. And whenever the middle ear is not able to drain the secretions, all the secretions of the middle ear will collect inside the middle ear cavity, and that condition is known as glue ear beta, because these are glue-like thick secretions collected inside the middle ear cavity. And this condition is also called as serous otitis media, secretory otitis media, or even otitis media with effusion beta. Clear? Because there is fluid collection. And as there is glue ear beta, the patient will have a fluid collected behind an intact tympanic membrane. Next important, the person will experience heaviness or fullness in the ear beta, but the patient will have no pain. Reason is, it is not a case of an infection, it is just fluid collection. So there is no pain or no earache as such. But as there is fluid collected in the middle ear, there will be difficulty in conduction of sound, and that is the reason beta why the patient is obviously going to complain of hearing loss beta. So the patient will have fullness in the right ear, and second, the patient will complain of a mild CHL or a conductive hearing loss. Now, impedance audiometry was done further beta, and it shows a type B curve. I hope all of you are quite aware that whenever the person is going to have glue ear beta, impedance audiometry will always show you a type B curve. What is that? We know impedance audiometry or tympanometry matlab, we will try to check the freedom of movement of the ear ossicles or the tympanic membrane. But whenever there is fluid collected inside the middle cavity, the tympanic membrane or the ear ossicles are not able to move freely beta. And that's the reason there is a type B or a flat curve which is observed. Clear? But that is important to be remembered. So here there is a flat or a type B curve which is going to be seen. Now they are asking you beta that the next step for the management of this patient is going to be. So we know as it is a confirmed diagnosis of glue ear or serous otitis media, what should be the next step in the management of this patient? Answer would be? Answer to this question has to be A, B, C or D. Answer to this question has to be yes. We know beta that if I talk about glue ear, so yaad rakhna, most common cause of glue ear, if they ask you, so we know the most common cause of glue ear is usually adenoid hypertrophy. Which is, what is adenoid hypertrophy? There is enlargement of the adenoids beta, right? Adenoid hypertrophy is nothing else but enlargement of the adenoids basically, that you have to remember. And those adenoids will cause a bilateral blockage beta of the eustachian tube because they grow inside the center of the nasopharynx. When the adenoids will get hypertrophied beta, they will block both the sided eustachian tube, leading to a bilateral glue ear, leading to a bilateral conductive hearing loss. But here beta adenoid hypertrophy is going to be unlikely. Why? Reason which is the patient is actually a 58-year-old male. Adenoid hypertrophy happens in school age children beta due to recurrent upper respiratory tract infection. So it could not be a case of adenoid hypertrophy. So what is the case basically beta? We know that if it is a more than 50-year-old patient and that too coming to you with a case of a unilateral conductive hearing loss, only they are saying 1 year is affected na, only there is fullness beta or fluid collection in 1 year, that is left ear. So definitely beta, a more than 50-year-old patient coming to you with a unilateral conductive hearing loss, you are actually going to think about query NPC beta. NPC is what? Nothing else but nasopharyngeal carcinoma. We know that nasopharyngeal carcinoma is going to be the most common malignancy of nasopharynx, and it will grow unilaterally. Second, it grows behind the eustachian tube opening, that is from the fossa of Rosenmuller. And whenever the nasopharyngeal cancer grows from fossa of Rosenmuller beta, it can grow in the front and it can block the eustachian tube, leading to a unilateral conductive hearing loss. And as it would be a case of unilateral conductive hearing loss beta, what should be the next step? The next step in the management of this patient has to be, now answer those who made a mistake earlier. Now I hope all of this is clear to all of you. So it has to be nothing else but beta option C, that is a endoscopy, a nasopharyngeal endoscopy should be done beta to rule out a nasopharyngeal pathology. Okay, next step in the management should be, अभी भी A कैसे बोल रहे हो यार तुम लोग? Why you are answering A? The answer has to be option C. Next step they have asked you na. So next step is what? Okay, next step definitely management is proper diagnosis karke, then we will go for treatment. That is called as management. Management is managing the patient, not only treating the patient. And management may you have to do a diagnosis first. So at least see na ki what is the diagnosis. It could be a case of nasopharyngeal carcinoma also. Don't you have to rule out that NPC? Reason is, chalo, even if it was a case of a small child and even if it was due to adenoid hypertrophy, still my next step would have been remained the same beta. Still my next step should have been endoscopy for nasopharyngeal pathology beta. Reason is, we know beta that we have to rule out now what is the cause for that glue ear. Otherwise what will happen? We will treat the glue ear, but again the eustachian tube was blocked. So again the patient will develop a glue ear beta. There will be a very high risk of recurrence if you're not going to treat the problem inside the nasopharynx. So see what is the reason for that nasopharyngeal, what is the nasopharyngeal pathology which is actually causing the eustachian tube blockage. So whether it is an elderly patient or it is a child beta, always go for next step as endoscopy to rule out any nasopharyngeal pathology. Clear about that is important. If they would have asked you that yes, what is the treatment in this patient? Yes, my treatment had to be beta, or what is the best management in the patient? Best. So yes, then my answer would have been option A beta, that is myringotomy with grommet insertion. That is, I am obviously going to make an incision over the tympanic membrane. I am going to drain all the fluid collected inside the middle ear cavity, and after that I am going to insert a grommet beta, which is a middle ear ventilation tube. Clear? So that is what is important to remember. Clear about that? Yes, we have to at least go for a posterior rhinoscopy or an endoscopy if possible beta. Reason is we have to see that why the child is actually having it beta. If you're not able to see the adenoids properly beta, the next step is always endoscopy. Reason is because we have to see now whether the child is having adenoid hypertrophy or not. Reason, if the child is having adenoid hypertrophy, along with this treatment, that is myringotomy with grommet insertion, you may also have to go for an adenoidectomy. Because if adenoidectomy would not be done beta, the patient's condition will not get treated properly. It will be an incomplete treatment, right? That's the reason you will try to understand what is the cause. And if they would have given that definitely, okay, the child is having adenoid hypertrophy already, then you don't have to think about it. Yet it can be anything beta. If it is a case beta of 12 to 14-year-old boy having epistaxis along with conductive hearing loss, it could be a case of nasopharyngeal angiofibroma causing ET blockage. It could be a case of rhinitis, or it could be a case of pharyngitis when definitely there was an edema around the eustachian tube opening that has caused the blockage. Okay, it could be a case of adenoid hypertrophy. It could be a case of any other tumor, just like a nasopharyngeal carcinoma. Hopefully clear? That is important. Now, if they ask you beta, option B, we know option B is Valsalva manure. Valsalva manure, it is, we have to do a deep inspiration, and after that we will do a forceful expiration beta with the nose and mouth closed. If you do a forceful expiration with the nose and mouth closed beta, the air will enter inside the eustachian tube and it will make the pressure inside the middle ear cavity positive, and it will push the tympanic membrane in front. So Valsalva manure is usually used beta for treating a condition whenever there is a retracted tympanic membrane. So in cases of retracted tympanic membrane beta, we will always go for a better treatment, that is Valsalva manure. And retraction of tympanic membrane happens beta in a case of barotrauma of ear or aero otitis media. Matlab, when there is sudden change in the air pressure, like during a sudden takeoff or during a sudden landing beta. Okay, so during a sudden takeoff or landing, definitely the person is actually going to have this problem. Which is clear about unilateral conductive hearing loss. They have said clearly the 58-year-old male patient having persistent fullness of left ear for 3 months. They have clearly repeated that the person is having fullness in the left ear along with hearing loss. Okay, they have given it is a case of unilateral hearing loss. And in NPC, why there is unilateral hearing loss? Because nasopharyngeal carcinoma arises from fossa of Rosenmuller from one of the sides. It is not going to be in the center. So as nasopharyngeal carcinoma is lateral, it will definitely only cause a eustachian tube blockage on that particular side itself. Clear? So that is what is important. Hopefully understood. So yaad rakhna. Next step has to be an endoscopy. Best management has to be myringotomy with grommet insertion beta. Antihistaminics and steroids would have been given if it was a case of any allergic pharyngitis or allergic rhinitis, because in allergic conditions there is edema around the eustachian tube causing blockage. So in those conditions, antihistaminics and steroids are going to help. Hopefully clear to all of you now. That is important. This is a classical picture of NPC beta, that is a nasopharyngeal carcinoma. Now when I talk about NPC or nasopharyngeal carcinoma, we know it is more common in patients more than 50 years of age. Anybody which is that infection that is known to increase the risk of NPC, which is the infection that causes nasopharyngeal carcinoma, let me know in the chat box. We know patients of nasopharyngeal carcinoma will definitely come to us with a complaint of neck swelling. Why? Because the most common clinical presentation in patients of NPC beta, it is not any mass in the nose. It is not any epistaxis beta. The most common clinical presentation is directly a painless metastatic cervical lymphadenopathy. Why? Reason beta, we know as the cancer arises from fossa of Rosenmuller, therefore it is a hidden cancer beta in the early stages. Okay, it is a hidden cancer in early stages. Therefore the patient sometimes directly comes to us in the advanced stages beta with a metastasis. The painless metastatic cervical lymphadenopathy beta will be the commonest presentation of a nasopharyngeal carcinoma. Here you are able to see this is the cancer beta which is growing. This is the cancer that is growing from fossa of Rosenmuller. So this is the endoscopic picture which can come to you. They can mark an arrow over here and ask you that what is this site. So this location which is behind the eustachian tube opening has to be a fossa of Rosenmuller. And we know the most common site beta for this tumor or this cancer to arise is always the fossa of Rosenmuller. Please tell me which is that infection. Very good, all of you. The infection that is associated with NPC or nasopharyngeal carcinoma, we have to remember it is EBV, that is Epstein-Barr virus. The Epstein-Barr virus infection is very commonly associated with nasopharyngeal carcinoma beta, that has to be remembered. Now this patient will have definitely painless cervical lymphadenopathy beta as the most common presentation. But if they ask you what is the triad present in patients of NPC, so let me know the name of the triad beta. I'll tell you the three features. The three features of the triad can be remembered by the same mnemonic, that is NPC. N stands for neuralgia. The patient will have a severe pain beta in the trigeminal nerve distribution, that is neuralgia. And that is usually seen due to fifth nerve involvement. We know na, as it is definitely a case of cancer beta, so it can erode the bone and it can also damage the nerves beta. So due to fifth cranial nerve damage, the patient will have severe neuralgia. Second, the patient is going to have palatal palsy. P stands for palatal palsy, which occurs due to involvement of the 10th cranial nerve or the vagus nerve. So due to 10th cranial nerve or vagus nerve palsy, the patient will have palatal palsy beta. And third, as the tumor grows in front and blocks the eustachian tube opening, there is a glue ear causing unilateral conductive hearing loss in the patient. Unilateral conductive hearing loss happens due to glue ear in the patient beta. Hopefully clear. What is the name of the triad? Very good. This was again a PYQ beta. The name of the triad that you have to keep in mind is nothing else but Trotter's triad. The Trotter's triad which is there beta, it is usually found in patients who are suffering from NPC, that is a nasopharyngeal carcinoma which is. Hopefully clear to all of you now. So these are the three features remembered by the mnemonic NPC as I've told you. Clear? If they ask you diagnosis, we know for diagnosis we have to do a nasopharyngeal endoscopy along with the biopsy beta. So nasopharyngeal endoscopy along with biopsy has to be done. And if they ask you what is the best treatment, if they ask you what should be the best treatment for an NPC patient, whether it should be chemotherapy, radiotherapy, chemoradiation or surgical excision, what should be the best treatment beta in a patient who is suffering from NPC or a nasopharyngeal carcinoma? The best treatment basically beta for a case of a nasopharyngeal carcinoma. Yes, so please remember it has to be chemoradiation. The answer has to be nothing else but chemoradiation that is simultaneous chemotherapy and radiotherapy. In a previous textbooks beta, it was only radiotherapy, but now it is chemoradiation which is considered as the best treatment. याद रखना, here also I have told you should go stage wise beta. Stage 1 and stage 2, मतलब T1 and T2 के लिए, okay, stage 1 and stage 2 के लिए we only go for radiotherapy, that's fine. But for stage 3 and stage 4, that is advanced cases में, we always have to go for a simultaneous chemoradiation beta. That is what is done. Surgery is usually not done beta in these patients. Surgery is only done in very rare cases when even chemoradiation is not effective. In only those cases we may try to opt for a surgery. Otherwise it is only chemoradiation beta that is given. Clear? Next is question number 6 beta, which states we are having a 35-year-old patient beta who underwent a prosthetic heart valve placement beta, and after the surgery she was started on aspirin tablet bache on discharge. She presents to the casualty with complaints like wheezing and breathlessness beta. What is the likely expected association in this patient? Now what is very clear? One thing is very clear, that whenever she was started on the aspirin tablet beta, she started experiencing wheezing and breathlessness. Matlab, obviously after taking aspirin, she is having these wheezing and breathlessness like complaint. Matlab, the patient is surely allergic to aspirin beta. So the one important feature is that the patient is allergic to aspirin, and aspirin is nothing else but a type of NSAID bache, that is a non-steroidal anti-inflammatory drug. The patient may be allergic to NSAIDs beta. That is the most important finding. We know whenever the person is allergic to aspirin, we know the person is atopic beta or actually having some allergic condition. And whenever the person is actually having some allergic conditions beta, you have to remember one thing, that allergic conditions agar hai, so it could be associated with a classical triad known as Samter's triad bache, right? It could be associated with a classical triad known as the Samter's triad. And I've told you to remember Samter's triad by a mnemonic beta, that is BAP or BAN. You can remember Samter's triad by the classical mnemonic BAP or BAN beta, where basically B goes for bronchial asthma. Okay, we know na, bronchial asthma is also an allergic condition. So these patients may surely have a bronchial asthma beta. So B goes for an bronchial asthma. Next important beta, A goes for what? Allergy to NSAIDs bache. A goes for allergy to NSAIDs beta. And N or P goes for what? N goes for nasal polyp, or you can remember P se polyp. So definitely beta, that is the important thing to be remembered. Clear about BAN or BAP has to be the mnemonic of Samter's triad. Now important is, yaad rakhna beta, here extrinsic asthma is also there an option and nasal polyp is also there an option. What will be a better answer? What would be a better answer beta? Whether it should be nasal polyp or it should be a extrinsic asthma? So we know the better answer to this question has to be beta, nothing else but option B bache, that is a nasal polyp. Reason, the asthma that is seen in patients of Samter's triad would be an intrinsic asthma beta. Okay, because the person is actually having a family history of asthma in these cases, the person is atopic beta. So as the person is atopic, definitely it would be an intrinsic asthma. Matlab, the patient is having asthma beta due to the genetic conditions. It is not extrinsic asthma which basically develops only due to allergen exposure. Clear? So that is the reason beta, the patient is having a intrinsic asthma. That is what is important to be remembered. So extrinsic asthma is not a part of Samter's triad. That is important. Option C says epistaxis. It is not seen. Drug interaction. No, it is not a case of drug interaction. So the common association will be nasal polyp. Now here you are able to see these are the two types of polyps that we have. The first one you are able to see beta, it is a polyp. Polyp is nothing else but the edematous nasal mucosa which is hanging out beta. So we know that definitely this is a case of an ethmoidal nasal polyp beta, which is growing inside the patient's nasal cavity. Now we know that ethmoidal nasal polyps which are there bache, they are usually more commonly seen in adults beta. These ethmoidal nasal, more commonly they are seen in adults beta, and it is seen in those patients. The ethmoidal nasal polyps are seen in those adults who are usually suffering from chronic allergy. It is mainly seen in those patients beta who are suffering from chronic allergy, like patients of bronchial asthma or allergic rhinitis. Important, here there will be bilateral polyps beta and they are going to be multiple. As the person is allergic only na, so there will be inflammation and edema in both the nasal cavities. So there will be a bilateral and multiple nasal polyps. Okay? And if they ask you what should be the treatment of an ethmoidal nasal polyp, we know here the edema is the main cause for the nasal polyp to form. So obviously to decrease that edema beta, we should give steroids. So steroidal nasal spray beta can be given. Fluticasone spray, that is given beta. So steroid nasal spray can be used beta in this patients initially. If that doesn't help, then we go for a surgery called as FES. So initially it is always a steroid nasal spray beta, but if it fails, then we go for a surgery known as FES, that is a functional endoscopic sinus surgery beta. Hopefully clear. Next important, if I talk about this picture over here, you are able to see beta a polyp. This was a previous year image based question of FMG exam beta. Here you are able to see a polyp which is growing from the nose or from the maxillary sinus of the patient. So from maxillary sinus it starts, it grows towards the posterior nasal opening called as choana, and then it grows down into the patient's oropharynx beta. So this is a classical antrochoanal polyp beta. This is a classical picture of an antrochoanal polyp, which we also call it as a Killian's polyp beta. This is a classical picture of an antrochoanal polyp, which we also tend to call it as the Killian's polyp. That is important to be remembered. Very good. So we know, if I talk about antrochoanal polyp or Killian's polyp, yaad rakhna, it is more commonly seen in children beta. What is the treatment of antrochoanal polyp? Let me know in the chat box. What is the treatment of antrochoanal polyp? Let me know in the chat box. We know that antrochoanal polyp is usually seen in children bache, and the more common cause is going to be chronic infection. A chronic infection causing inflammation and edema again leads to formation of this antrochoanal polyp beta. So we know most commonly it is seen in children and it is due to chronic infection. We know this is going to be unilateral beta because it starts from the maxillary sinus, that is antrum, and grows towards the choana beta. So it is not associated with allergy. So it is always unilateral beta. And secondly, it is going to be single beta. So unilateral and single it is, unlike the ethmoidal nasal polyp, which was bilateral and multiple. We know beta the treatment in patients of antrochoanal polyp, if they ask you. We know we cannot give steroids in a small child beta. And as you cannot give steroids in a small child, the treatment is directly FES beta. What is FES? Functional endoscopic sinus surgery beta. It can be present in elderly but less common. More commonly it is seen in children. Treatment has to be directly of FES. FES is nothing else but functional endoscopic sinus surgery itself. Okay, because steroids are not used in children. And any which ways, please remember that polyp is going from the maxillary sinus. So here it is important to remove the polyp directly from the maxillary sinus. For that we have to go for a FES surgery, that is a functional endoscopic sinus surgery. Which hopefully clear to all of you now. Next, yes, polypectomy has to be done endoscopically, that is done in FES. Another important question. Okay. Only tuning fork test, audiometry, and this third part, that is bithermal caloric test. These are the only difficult topics. Otherwise, everything is easy in ENT. Clear? Question number 7 is they ask you performed a bithermal caloric test beta on a person when you irrigated his right ear beta with cold water. When you irrigated his right ear with cold water, you notice there is rapid movements of the eye. We know rapid movements of eye is known as nystagmus. So the person was having rapid movements of eye nystagmus towards which side? Opposite side. This also we know that whenever we perform a bithermal caloric test, once with cold water and once with hot water beta or warm water. With cold water, the nystagmus is always seen towards the opposite side beta. Okay, which among the following corresponds to the correct interpretation beta of the nystagmus in this test which is seen? So here definitely we were performing the test in the right ear beta. I hope all of you are quite aware that whenever we perform a bithermal caloric test, we are actually talking about the ocular reflexes or the vestibular ocular reflex beta. That is what? That whenever we will push water inside the external auditory canal of the patient, and due to that water, if the temperature of the external auditory canal changes, the vestibular ocular reflex is activated. And due to that vestibular ocular reflex, my patient is going to have nystagmus in the eyes beta. That is rapid to and fro movements of the eyeball. Now, if I talk about beta, the first condition, when I'm irrigating the external auditory canal beta with the cold water is going to be at 30 degrees centigrades. So whenever I push cold water, for example, in my patients, right bola no ne ha. So if I definitely beta irrigate my patient's right ear beta with cold water, so what is going to happen? The nystagmus will always be seen towards the opposite side beta. And when I say nystagmus is seen towards the opposite side, matlab kya? We know nystagmus has two components beta. One rapid and second slow. One rapid and second slow. So one there is a fast component, the second is the slow component beta. So here you can see beta, we know that the fast component is going to decide the direction of nystagmus. Always the fast components decide the direction of nystagmus. So here in this case beta, if I say that as we have irrigated the ear with cold water, the nystagmus will be towards the opposite side. Matlab, as you have irrigated the patient's right ear, we know beta, the nystagmus should be towards the left side. And when I say nystagmus should be towards the left side, matlab, the fast component should be towards the left side beta. Right? The fast component of the nystagmus should be towards the opposite side or the left side. So here as we have irrigated the right ear with cold water beta, the nystagmus was towards the left side. Matlab, the fast component was towards the left side. Answer to this question has to be option A beta. Clear? We know that slow components towards right side, you will say that, so this would be also answer. No. Reason beta, slow component does not decide the direction of the nystagmus. You always have to give the direction of nystagmus by the fast component. So that's the reason definitely the better answer to this question has to be option A. Clear? Now second time beta, what we are going to do, we are actually going to irrigate the external auditory canal with warm water. And when I irrigate the external auditory canal with warm water will be at 44 degrees centigrade beta. Whenever you will push warm water in the patient's external auditory canal, then you will observe beta that the patient's nystagmus is towards the same side. I am irrigating the right ear of my patient with warm water, so the nystagmus is towards the same side. When I say nystagmus is towards the same side, matlab the fast component of nystagmus is towards the same side. If they would have said that during the bithermal caloric test, we have irrigated the right ear with warm water beta, okay, and the nystagmus was observed to the same side, then we would have said that the fast components would be towards the right side beta. Okay, so that is important. Yahan dekh sakte ho, in cold water beta, you can see the nystagmus is towards the opposite side. That means the fast component is towards the opposite side. In warm water, you can see beta, the nystagmus is going to be towards the same side, matlab the fast component is going to be towards the same side. I hope all of you are quite aware. That is cow's mnemonic beta that we always remember, that has been given in the Dhingra textbook as well. तो याद रखना, cows का मतलब होता है cold water के साथ there will be an opposite sided nystagmus, and warm water के साथ there is always a same sided nystagmus. Hopefully clear to all of you now. Chalo. And always remember that the direction of nystagmus should always be given by the fast component of the nystagmus. Hopefully clear to all of you now. Next important is question number 8 beta. If I talk about question number 8, here we are having a 45-year-old female beta who comes to the ENT OPD with complaints like long-standing history of a mucopurulent ear discharge. Yaad rakhna, here the patient is actually having a long-standing history of a mucopurulent ear discharge beta, along with earache and mild hearing loss beta. On otoscopy, they are saying there is a central perforation beta which was observed on the tympanic membrane. And pure tone audiometry shows there is a poor air conduction in the patient. On pure tone audiometry, you are able to see there is a poor air conduction beta with a significant AB gap which was noticed beta. CT scan done reveals that the malleus and the incus of the patient have been eroded. So it is an M-I- situation where malleus and incus both have got damaged. Which among the following will be the most appropriate management? Earlier I have always told you that whenever a clinical case comes to you beta, always give me a provisional diagnosis of the case beta. Whenever a clinical case comes to you, always give me a provisional diagnosis beta of the case. Now, whenever I talk about provisional diagnosis of the case, bache, so what is going to be the provisional diagnosis? Let me know. What should be the provisional diagnosis of the case? Very good. We know that the patient is actually having beta a history of mucopurulent ear discharge. I've always told you, mucopurulent ear discharge is a feature of otitis media. Whenever there is a middle ear infection beta, there will be a mucopurulent ear discharge, but here they are saying there is a long-standing history, so it cannot be a case of ASOM or acute suppurative otitis media. As there is a long-standing history, it has to be a case of CSOM, that is chronic suppurative otitis media. Now we know CSOM are of two types beta. One is a safe CSOM, second is an unsafe CSOM beta. When I say safe CSOM bache, that is a tubotympanic CSOM. Here what happens? The infection is only limited to the middle ear cavity beta. The infection does not damage the walls and therefore the infection does not spread outside the middle ear. So we know in safe CSOM beta there will be a central perforation in the tympanic membrane. But unsafe CSOM agar hota beta, so unsafe CSOM known as atticoantral CSOM, in that condition there is formation of cholesteatoma, and that cholesteatoma is known to damage or erode the walls of the middle ear. In unsafe CSOM, as the walls of the middle ear are eroded beta, therefore the infection spreads outside the middle ear cavity bache. Okay? That is a case of unsafe CSOM. And in unsafe CSOM on tympanic membrane, we are able to find a marginal perforation beta, not a central. So as there is a central perforation which is seen, it has to be a case of safe CSOM or a safe chronic suppurative otitis media beta. That is a classical case beta. Now once you have diagnosed this condition, we know that pure tone audiometry says the patient is having poor air conduction along with significant air gap, AB gap. We know beta, whenever the air conduction is poor only along with a significant AB gap, we know it is a case of nothing else but CHL. What is CHL? Conductive hearing loss. And any which ways we know beta, whenever a patient will have CSM or middle ear infection, patient will have a conductive hearing loss only beta. CT scan done reveals there is a malleus and incus ka erosion. We know where if the malleus and incus have got eroded beta, the ear ossicle continuity is lost. And if the ear ossicles are not in continuity, that's the reason why the sounds are not conducted further, leading to a conductive hearing loss or CHL in the patient. Clear about? Now we know in cases of safe CSM or a tubotympanic CSM, what is the treatment? There are various conditions beta. Okay, and for those conditions I have to do a surgery called as tympanoplasty. Now when I say tympanoplasty, it is nothing else but repair of the middle ear cavity is called as tympanoplasty, which is done for CSM cases. There are total 5 types of tympanoplasty that I've told you. Understand one by one. If I talk about beta, the first one, type 1 tympanoplasty mein what is done beta? We just do a myringoplasty over here. Now what is myring? Myring means tympanic membrane. So in type 1 tympanoplasty beta, there's the condition like M plus, I plus, S plus situation. Matlab, the malleus, incus and stapes, all of them are absolutely normal. When the malleus, incus and stapes are all normal beta, none of them is eroded. You can see this is malleus, this is incus and this is stapes. All the 3 ear ossicles are absolutely normal beta. So in this condition, only one thing we have to do, and that is we just have to repair the tympanic membrane perforation. And to repair the tympanic membrane perforation, we have to place a graft beta. Okay, a temporalis fascia is used as a graft. We just have to use that graft beta and place it below the tympanic membrane perforation. And as we are only repairing the tympanic membrane perforation beta, we call this procedure as tympanoplasty. Myringoplasty beta. So type 1 tympanoplasty which is there beta, it is nothing else but a myringoplasty. So type 1 tympanoplasty is nothing else but a myringoplasty, which is that is important to remember. Clear about? Next condition now. Here you are able to see beta. You can see the patient's malleus. If you compare the malleus in the first and second picture, you can see beta in the second picture the malleus of the patient is gone. Yes, incus and stapes are still present beta. So if they say definitely in the second picture what is seen. याद रखना second picture में it is a case of M minus I plus S plus situation. The second condition में malleus has been eroded or the malleus is gone beta, but incus and stapes are still present. In this condition, what we do? We remove the eroded part of the malleus beta. So whatever has been eroded in the malleus bache, we have to remove all the eroded part of that malleus, and then I have to place the tympanic membrane graft directly over the incus beta. So here we will definitely go for a beta, a myringo-incudopexy. Okay, the myringo-incudopexy matlab fixing the myring, that is fixing the tympanic membrane graft directly over the incus beta. This procedure is myringo-incudopexy, also called as a type 2 tympanoplasty. Yeah? So this myringo-incudopexy which is there, which is not malleus. Okay, so myringo-incudopexy which is there beta, this surgery which is there, it is basically called as a type 2 tympanoplasty. It is done in M minus I plus S plus situation. Let's talk about the type 3, which is the commonest surgery we perform. What is done in this surgery? Understand. In this surgery beta, you can see that if you compare the first picture on this third picture, you are able to find beta that in this condition neither malleus is present nor incus is present. Matlab it is M minus I minus S plus situation. So whenever the malleus and incus both have been eroded, only stapes is present inside the middle ear cavity. That condition is called as M minus I minus S plus situation. In this condition, what we do? We directly remove the eroded malleus and incus and we directly place the tympanic membrane graft over the stapes. As you directly place the tympanic membrane graft over the stapes, fixation of tympanic membrane graft over the stapes will be called as myringo-stapediopexy beta. Okay, this procedure is called as myringo-stapediopexy, also called as a type 3 tympanoplasty. Okay, it is also called as a type 3 tympanoplasty. Myringo-stapediopexy, also known as a type 3 tympanoplasty. Hopefully clear to all of you. So this is another important one. So the first and the third are very, very important beta. So M plus I plus S plus situation mein you go for type 1, that is myringoplasty. For M minus I minus S plus situation mein you go for type 3, that is myringo-stapediopexy. These two are very important. Now let's talk about the third one beta. Sorry, the fourth one beta. In fourth one, what we are able to see, you can see beta that the patient is having M minus I minus S minus situation. Matlab even the stapes is gone now, right? So when there is a M minus I minus S minus situation, when all the 3 ear ossicles in the middle ear have been eroded or have been damaged beta, in this condition, what we do? We place the tympanic membrane graft beta. We place the tympanic membrane graft definitely directly over, okay, directly over the oval window beta and the semicircular canal. We know na the horizontal or the lateral semicircular canal beta is in connection with the middle ear. Matlab it is having a common wall between with the middle ear beta. So we know definitely in this condition I am going to place the tympanic membrane graft directly over that lateral or the horizontal semicircular canal beta and on the oval window which is. So this graft is going to cover both of them. This is what is called as a type 4 tympanoplasty. Not very commonly done. Yeah, so that is important. Reason is, instead of this, nowadays beta, we tend to use a total ossicular replacement process. Yes. So nowadays, why type 4 tympanoplasty is not very commonly done? Reason is, in this surgery beta, we better use a TORP, that is total ossicular replacement processes. When malleus, incus and definitely stapes is also gone. Usually we know it will only be a stapes ka head which will be lost beta. The footplate of stapes will still be intact. Reason is, we know footplate of stapes is derived from the neuroectoderm, so that it has a different blood supply beta. So इसीलिए the footplate of stapes is always spared in chronic separative otitis media. So in this condition beta, I can use total ossicular replacement processes beta. Okay, that is a TORP. ठीक है, तो याद रखना है बात. Next important, if I talk about type 5. Now type 5 में here you can see beta, the malleus and incus have been gone. So it is M minus I minus S plus situation beta. Okay, yes, stapes is present, but the problem is what? There is a fixed stapes over here beta. Even if stapes is present beta, the stapes is not able to move only properly, and if the stapes is not able to move properly beta, that is going to cause a problem. So what we do, we know that if the stapes is not going to move itself beta, it will not be able to conduct the sound. So better than that, we directly place the tympanic membrane graft over the lateral or the horizontal semicircular canal. So what we do, we make an opening beta in the lateral semicircular canal. We make an opening over the lateral semicircular canal bulge, and over that bulge beta, I am going to cover that bulge with the tympanic membrane graft. Okay, and as I have created an opening, that is called as fenestration. So type 5 tympanoplasty is also called as a fenestration operation beta. So type 5 tympanoplasty mein, as you create a fenestration over the lateral semicircular canal, it is also called as a fenestration surgery or fenestration operation, over which you are actually going to place the graft. So now, what will happen? The sounds will not go inside the inner ear via the oval window. The sounds will go inside the inner ear directly via the lateral semicircular canal beta. Okay, so that is what is important to remember. No issues with this. So yaad rakhna hai. It is used in M minus I minus S plus situation, but when the stapes is fixed beta. Hopefully clear to all of you now. That is what is important. Okay, yaad rakhna hai. Please remember beta, partial ossicular replacement processes of PORP, it is only possible to use beta when the stapes is not fixed. तो स्टेपिस अगर फिक्स्ड है तो पॉर्प नहीं यूज होगा. पॉर्प इज यूज्ड ओवर हियर as an alternative to type 3 tympanoplasty or laryngoscopiopaxy when the stapes is normal. So whenever beta we have an option of we have a condition of M minus I minus S plus situation. In this condition, another surgery which is there beta, it is nothing else but PORP, that is a partial ossicular replacement prosthesis. Clear baat? So this is the PORP beta, that is a partial ossicular replacement prosthesis that we are going to use. And this is used generally whenever the malleus and incus have been eroded, that is M minus I minus S plus situation. Whereas this, the second one which is longer beta, it is a TORP, that is total ossicular replacement processes, and that is generally used beta when there is a situation like M minus I minus stapes head minus situation, when only footplate of the stapes is left. Clear? Then we have to use a longer processes beta. Both of these processes are made up of titanium or Teflon, therefore they are MRI compatible nowadays. Clear? Chalo, so coming back to the question beta, here they are saying the patient is having M minus I minus S plus situation. Why I would say that? They have said that the malleus and the incus of the patient have been eroded, but the malleus and incus of the patient have been eroded, but the stapes is normal. So it is a M minus I minus S plus situation. We know whenever it is a M minus I minus S plus situation, I have two options beta. Okay? I have two options in this condition basically. One option is what? One option is this surgery beta, that is a type 3 tympanoplasty called as a laryngoscopiopaxy, or another option is a PORP beta, that is a partial ossicular replacement processes. Both of these options, any of these options can be used beta. Okay? We know that this type 3 tympanoplasty beta or a laryngoscopiopaxy is also called as columella tympanoplasty. Reason, stapes ka Latin name is columella beta, therefore type 3 tympanoplasty is also called as columella tympanoplasty. Out of both of them, what is there in option? We know. In option, we have option B, that is columella tympanoplasty, also called as a type 3 tympanoplasty beta or a laryngoscopiopaxy. PORP or partial ossicular replacement processes is not an option. So we have to go for option B beta as the answer. TORP or total ossicular replacement prosthesis would have been used beta if it was the case of M minus I minus stapes head minus situation. If they would have said that even the head of the stapes have been eroded, then I would have answered it as option D beta. Type 2 tympanoplasty, Type 2 tympanoplasty is done beta when only the Marius is eroded. But here not only the Marius but even the incus has got eroded beta. So I cannot go for a type 2 tympanoplasty or a myringo-incudopexy. Okay, myringoplasty, it is always done beta only in those conditions where definitely all the three ear ossicles are present beta, that is M plus I plus S plus situation. When all the three ear ossicles are present, only the problem is beta that the patient's tympanic membrane perforation is there. So on those conditions I have to go for a myringoplasty or a type 1 tympanoplasty. And TORP I have told you M minus I minus S head minus situation. Hopefully clear to all of you. The answer has to be option B, that is the type 3 tympanoplasty or a columnar tympanoplasty. Question number 9. Sarkari question of your exam. A 16-year-old male beta comes to you with complaints of nasal obstruction. Along with nasal obstruction, patient is having proptosis beta, that is protrusion of the eyeball, along with a recurrent profuse epistaxis. On examination, it was found that a mass is seen inside the patient's nasopharynx vache, and the CECT scan, there is a contrast enhanced CT scan which was done beta, it has been given below. What is the likely management in this patient? They are asking you. What is the likely diagnosis? Okay, so here we are able to see beta 16-year-old male coming to you with recurrent profuse epistaxis along with nasal obstruction and proptosis. We know whenever a teenager or adolescent patient comes to you with nasal obstruction, a recurrent epistaxis and proptosis, it has to be a case of nothing else but, very good, the diagnosis of the patient has to be a Sarkari case of JNA. And when I say JNA, we know it is a case of juvenile nasopharyngeal angiofibroma beta. So there is a vascular tumor arising from the patient's nasopharynx beta. It is usually seen in the juvenile age group less than 18 years of age, especially in 12 to 14 year old children beta. Important is these children will have main two complaints. One is a nasal obstruction, second is recurrent profuse epistaxis. Reason, we know that juvenile nasopharyngeal angiofibroma is a highly vascular tumor. As it is a highly vascular tumor beta, that's the reason the patient is going to have these two important symptoms beta. Clear है बात? याद रखना. Now important is CECT was done. Why CECT? Reason is beta, we know biopsy is absolutely contraindicated in this case. Why biopsy is contraindicated? Because we know it is a highly vascular tumor. So biopsy will be absolutely contraindicated. Therefore, we have to go for a CECT scan, which is the investigation of choice. And when we go for CECT scan, this is the classical picture that is observed. What is seen? Here you can see better there is a mass arising from the center of the nasopharynx from the spinopalatine foramen, which is the most common site of origin, spinopalatine foramen. And from there, the mass has grown beta, and it is actually growing laterally behind the cheek or behind the maxilla beta in the pterygomaxillary fossa. And when the mass grows in the pterygomaxillary fossa, you can compare that the posterior wall of the maxillary sinus has been pushed forward. Whenever the posterior wall of the maxillary sinus is pushed forward, that is called as with sign. This was a previous year question of FMGE exam. They have given this kind of a CECT in a patient of juvenile nasopharyngeal angiofibroma and asked you that what is the likely sign that is observed beta on this CECT scan. We know this likely sign that is observed beta, it is nothing else but a case of the antral sign, also called as the Hallman-Miller sign beta. Either you can call it as the antral sign bache, or we can call this as the Hallman-Miller sign. Whenever there is an antral or Hallman-Miller sign on the CECT beta, that has to be a confirmed diagnosis of nothing else but juvenile nasopharyngeal angiofibroma. Okay, so please tell me what should be the likely treatment of the patient now. A, B, C or D. So we know most common site of origin I have told you spinopalatine foramen se hota hai originate. That is important. And we know proptosis along with broadening of nose if it is seen, that is classically called as the frog face deformity beta. Another important feature that can be seen in this child is also going to be a frog face deformity which can be seen. Barabar? The name of classification that is used for staging, I have told you that was a PYQ and FMGE exam. The name of the classification that is used for staging, always remember that classification is either called as a fish classification or a Radkowski classification beta. Either we are going to have a fish or a Radkowski classification which we have discussed. Okay? The fish or the Radkowski classification is used for juvenile nasopharyngeal angiofibroma. Very good. So we know beta the treatment has to be nothing else but option D beta, that is nothing else but a surgical excision. Reason, we know beta that though it is a vascular tumor, but pre-operatively we will go for an angioembolization, and after going for an angioembolization beta, Obviously, the likely management or the best management in the patient has to be a surgical excision beta. Because if you embolize the maxillary artery or the blood vessel supplying the tumor, the blood supply of the tumor is going to decrease and therefore there will be less bleeding during the surgery beta. Surgical excision has to be the best treatment. याद रखना है बात, ठीक है. So this is the classical picture of juvenile nasopharyngeal angiofibroma, where you are able to see beta the classical cheek swelling because the tumor is growing laterally beta in the pterygomaxillary fossa, ठीक है. And second, when it grows into the orbits beta, when it grows behind the orbits, then you are able to see this classical frog face deformity, where you are able to see that the child is actually having beta a broadening of nose. Along with that, the child is having protruded eyeballs called as proptosis. So these two features are usually seen. Yeah, we know this is the Radkovsky staging beta that is generally used in cases of juvenile nasopharyngeal angiofibroma बच्चे, ठीक है. So this is the Radkovsky staging that you have to just go through it once. That is not very important, ठीक है. They have not asked even single question on the staging. They've just asked you the name of the staging. So fish or the Radkovsky staging can be used. Clear? Question number 10 beta. If they ask you now, here we are having a 43-year-old male patient बच्चे who is suffering from recurrent episodes of vertigo. Along with that, the patient is also having hearing loss beta, and along with hearing loss, patient is having a fluctuating tinnitus for the last 3 years beta. The episode has nausea and vomiting beta. The patient also has nausea and vomiting whenever the person is having an episode of this condition, along with vertigo. The episode settles beta in few hours only. मतलब within few hours the person gets back to normal. So it is going to be a episode which lasts for only few hours. What is the best step to diagnose the patient's condition? What is the best step they have asked you beta to diagnose the patient's condition? Now what is the likely diagnosis of the case? What is the likely diagnosis of the case? A middle-aged male beta, a 43-year-old male, a middle-aged 3rd or 4th decade male, coming to you with episodic disease beta, where the episode only lasts for a few hours beta. Very good. So we know definitely it is a case of, yes, so if it is recurrent episodes definitely of classical 3 symptoms. One is vertigo, along with that the patient having fluctuating tinnitus, okay, and third important feature, the person having hearing loss. So I hope all of you are quite aware. Jahan pe there is a classical triad of vertigo along with tinnitus and hearing loss beta. It has to be a classical diagnosis of which condition? It has to be a classical condition of nothing else but Meniere's disease. कहाँ से BPPV हो गया? In BPPV, the patient only has vertigo. Is there any hearing loss in patients of BPPV, benign paroxysmal positional vertigo? Is there any hearing loss in patients of BPPV? Never. There is no damage to cochlea. कहाँ पे hearing loss होगा patient में? Why there would be tinnitus usually? Tinnitus again not a common feature of BPPV. Only vertigo will be seen in patients of BPPV, and that too on changing the head position. Okay? Not normally. So therefore the diagnosis of the patient has to be Meniere's disease, which is more common in the middle-aged patients and having recurrent episodes like migraine, which only lasts for a span of few hours or one day beta. Clear about that is important. And along with that, we know in cases of Meniere's disease, if they have asked you what is the best step, they have not asked you the next step beta, they have asked you best step. Okay? Then what is going to be your answer? We know Meniere's disease may, as the person is having hearing loss, we can go for a PTA, that is a pure tone audiometry. And when we go for a pure tone audiometry, this kind of an audiogram is seen. On an audiogram, but I hope all of you are quite aware that the brackets or the dotted line is going to represent the bone conduction, and the crosses or the thick line is going to represent the air conduction. Yeah, right. Now here you can see both the lines should always be less than 25 decibel. Matlab they should be in this range beta. Whenever both the lines are less than 25 decibels beta, in this range, then we say the person is having normal hearing. But obviously here you can see both the lines are beyond 25 decibel. If both the lines are beyond 25 decibel, matlab the person is suffering from a hearing loss. So here you can see beta, both the bone conduction and air conduction line are less than beyond 25 decibel. We know when both the bone conduction and the air conduction line are beyond the 25 decibel, matlab both the air conduction and bone conduction are poor. And when both the lines are poor, we know it is a case of SNHL, that is a sensory neural hearing loss. We know now in Meniere's what is going to happen. Meniere's disease mein beta, we know that the patient is actually going to have problem with the endolymphatic sac. The endolymphatic sac is not able to properly absorb the endolymph, and due to that the endolymphatic pressure is going to constantly increase, leading to gradual damage to cochlea. And whenever the cochlea of the patient is damaged, patient will always have a SNHL or a sensory neural hearing loss beta. And that's the reason why both the air as well as the bone conduction of the patient is going to be poor beta. Hopefully clear to all of you. Another feature, we know in Meniere's disease, usually there is damage in the early stages beta to the apex of the cochlea. As the apex of the cochlea is damaged, therefore, the person will have a low frequency hearing loss in the early stages. As the person is having low frequency hearing loss in the early stages beta, because the apex of the cochlea has been damaged. Okay? We know the apex of the cochlea, if it is damaged, that leads to low frequency hearing loss. And whenever the basal tone of the cochlea is damaged, that leads to a high frequency hearing loss. As here the apex of the cochlea would have been damaged, that's the reason the person is having a low frequency hearing loss. And due to that, we are able to get a very classical audiogram beta called as a rising audiogram. We are able to get a classical audiogram known as rising audiogram. That is a very special feature in patients who are suffering from Meniere's disease beta. So rising audiogram is seen in Meniere's disease. Anybody? Sloping audiogram will be seen in patients suffering from which condition? Sloping audiogram will be seen in patients suffering from which condition? Rising audiogram is a feature of Meniere. Sloping audiogram will be a feature of presbyacusis beta. That is nothing else but age-induced hearing loss. The presbyacusis or age-induced hearing loss mein the person is actually going to have beta a sloping audiogram. That is important. Why? Because in age-induced hearing loss, the basal tone of the cochlea gets damaged in the early stages, and therefore in presbyacusis, patient has a high frequency hearing loss beta, and that's the reason definitely the person will have a sloping audiogram. Hopefully clear to all of you now. That is important. Clear? Next, यहाँ पे Meniere's disease में if they would have asked me next step, I would have definitely answered it as pure tone audiometry. The first line investigation or the first step, if they would have asked me, I would have surely gone for pure tone audiometry. But here they are not asking you about first step. Here they are asking you best step to diagnose Meniere's. We know the best step to diagnose Meniere's is nothing else but option D beta, that is electrocochleography. Okay. Investigation of choice for diagnosis of Meniere's disease has to be option D, that is the electrocochleography beta. याद रखना है बात. Dick-Solpike maneuver is a diagnostic maneuver to confirm a case of BPPV or a benign paroxysmal positional vertigo. ठीक है, अगर BPPV होता then I would have said we have to go for Dick-Solpike maneuver. Glycerol test is done in the diagnosis of Meniere's disease only, but it is not the best investigation. It is done alongside with electrocochleography. Clear about that is important. If they ask you beta what is the treatment in the patient of Meniere's disease, so do remember that. If I talk about treatment, we know during an episode beta, when the patient is having an episode of Meniere's disease, during that episode, the most important or the most disturbing symptom is vertigo. So during an episode beta, we have to give anti-vertigo drugs to the patient like cinnarizine, promethazine, prochlorperazine. These kind of anti-vertigo drugs should be given beta. Next, between the episodes beta, between the episode, if they ask you, definitely the drug which has to be given is known to decrease the endolymphatic pressure. The drug which can decrease the endolymphatic pressure is a carbonic anhydrase inhibitor known as acetazolamide. So acetazolamide will be given between the episodes to decrease the endolymphatic pressure beta. That is important to be remembered. Now, even after giving these drugs, if the patient's condition doesn't improve beta, if the patient's condition doesn't improve definitely, so please remember beta, then what should be done? So याद रखना, in those conditions beta, we have to go for definitive management. Definitive management depends whether person is having a residual hearing or not. मतलब whether the affected ear is completely damaged or it is partially damaged. You have to check whether there is any residual hearing or not beta. In case if the ear is partially damaged beta, that means the residual hearing will be present, but the person will be able to hear with that ear beta somewhat. So in those conditions, we will try to save that ear beta, and that's the reason we go for a endolymphatic sac decompression surgery. Whenever residual hearing is present, we go for a endolymphatic sac decompression surgery. Let me know in the chat box about the surgical landmark for endolymphatic sac. What structure is considered as the surgical landmark for endolymphatic sac? Let me know. Whereas if I say that the residual hearing of the patient is absent beta, when I say residual hearing of the patient is absent, iska matlab hai the cochlea or that particular ear is completely damaged, and when the ear is completely damaged, that's the reason beta person is not able to hear anything. So in those conditions, better kill the inner ear completely, and killing of the inner ear which is there beta, it is usually done by chemical ablation of inner ear. We have to do a chemical ablation of inner ear beta by directly injecting a highly ototoxic drug inside the inner ear, and that highly ototoxic drug is nothing else but Gentamicin beta. So we have to inject a drug like gentamicin inside the inner ear, which will kill the inner ear completely. That is called as chemical ablation of inner ear. Very good. Donaldson's line beta is actually going to be the surgical landmark. Okay? So Donaldson's line is actually the surgical landmark beta. Okay? For the endolymphatic sac. Now, if they ask you refractory cases, what is the treatment of refractory case of Meniere's? Anybody let me know in the chat box. What is the treatment for refractory case of Meniere's? Refractory matlab when the patient doesn't respond to anything. When the person doesn't respond to anything beta. Whatever treatment options are available, for any of the treatment options, the person is not responding only. So in those conditions of Meniere's disease, what is the treatment of choice? Very good, shabash. So we know beta that whenever there is a refractory case of Meniere's disease beta, when the inner ear has got completely damaged, bache, in those conditions basically we have to remove the inner ear. We know inner ear is known as labyrinth, and therefore the surgery has to be called as a labyrinthectomy, bache. We have to go for a surgery known as a labyrinthectomy. Clear? But that is what is important. That is only done for refractory cases, not in the other cases. Clear? I hope all of you are quite aware about the phenomena that you find in Meniere's disease. First, we know beta in a patient of Meniere's disease, there would be what? The patient definitely beta may be able to hear the sounds of two different frequencies. Whenever a person can hear the same sound in two different frequencies, that is called as diploacusis beta. Second, the person definitely has a problem beta where the loud sound appears more loud. Matlab, the patient will hate to go into noisy areas beta. Why? Because the loud sound will appear more loud to the patient. There is an abnormal perception of loud sound, and that is called as a recruitment phenomena beta. That is known as a recruitment phenomena. Third important, whenever the person whenever the person hears a loud sound beta, he starts experiencing vertigo. Chakkar aane lagte hai badi आवाज पे. ठीक है? So whenever a person experiences loud sound beta, the person experiences vertigo, and that is known as Sturios phenomena. So these are going to be the various phenomena beta that you have to remember, which will be found in a patient of Meniere's disease. Which है. Hopefully clear to all of you now. That is important to be remembered. Clear? Sure. So these are the important points that you need to keep in mind. Shabash. Now, these two manures beta, we know these are the manures that we perform in the case of BPPV बच्चे, that is benign paroxysmal positional vertigo. यहाँ पे क्या होता है? We know that the autoconia or the otolith, matlab the calcium carbonate crystals beta which are present in the utricle and saccule, these autoconia or otolith beta, they may get free and they may enter beta into the patient's semicircular canal whenever the patient changes head position. Now when these autoconia enter into the patient's semicircular canal beta, these crystals will cause disturbance in the semicircular canal. And as semicircular canal are responsible for the angular balance of the body, as they get disturbed, the patient's angular balance gets disturbed beta, leading to vertigo. This vertigo will only appear when the autoconia enter into the semicircular canal. Matlab, this vertigo will only appear when the patient changes the head position beta, and it will start all of a sudden. That's the reason we call this condition as benign paroxysmal positional vertigo. Please tell me that benign paroxysmal positional vertigo is the most common cause of central vertigo or peripheral vertigo. We have discussed this. BPPV is the most common cause of central or peripheral vertigo. Let me know in the chat box. We know in cases of BPPV beta, what is the common complaint of the patient on changing head position? Patient experiences vertigo. So जब भी on changing head position, the patient is going to experience vertigo beta. That case is the classical case of BPPV. In patients of BPPV, whenever we have to diagnose a case beta, whenever we have to diagnose a case of BPPV, we have a classical diagnostic manure beta. Okay, very good. We know that BPPV is the most common cause of peripheral vertigo, because if there is damage to the brain, then it is called as central vertigo. Whenever there is damage in the ear, that is called as a peripheral vertigo. Okay, it is the most common cause of peripheral vertigo. Now, whenever you have ruled out all the other causes of vertigo and you have come down to a conclusion that the patient is suffering from BPPV, याद रखना BPPV में you have to do the investigations to rule out all other causes of vertigo, and do remember here the person will have an absolute normal hearing beta, absolutely normal hearing on audiogram. Clear? Now in this condition, how to confirm a diagnosis of BPPV? Here you have to stand behind the patient beta and you have to make the patient sit, okay, and the patient should be facing No, okay. So for example, the patient is facing in front, we have to stand behind the patient. And now when I stand behind the patient, I have to hold the head of the patient and suddenly bring down the patient beta. As you suddenly bring down the patient's head beta and you suddenly rotate the patient's head in one of the direction, what is going to happen? As you suddenly bring down the patient and suddenly changes head position beta, the patient suddenly starts experiencing vertigo beta, or you are able to observe the nystagmus in the patient's eyes. If the person starts experiencing vertigo or you are able to observe nystagmus in the patient's eyes beta, matlab the patient is suffering from benign paroxysmal positional vertigo. And this we know is a two-step maneuver beta. Okay, we have to turn the head to on right side once and on left side once beta. Okay, this is a two-step maneuver. Here obviously a doctor or an examiner, as you are able to see, a doctor or an examiner is going to be present beta. Reason, this is a diagnostic maneuver, and this diagnostic maneuver of BPPV beta we know D for diagnosis, D for Dix-Hallpike maneuver. So this diagnostic maneuver of BPPV bache is basically called as the Dix-Hallpike maneuver. The diagnostic maneuver of BPPV is classically known as the Dix-Hallpike maneuver beta. Hopefully clear. Next important, if I talk about treatment beta, treatment ke liye also you are going to treat a maneuver to the patient, but this is going to be a 5-step cyclical maneuver. Okay, it is a 5-step cyclical maneuver, and here there will be no doctor beta, because the person is going to perform this maneuver on his own beta. It is for the purpose of treatment. So whenever a person experiences BPPV, he will immediately perform this maneuver beta to get rid of that BPPV, and this is classically known as the Eppler's maneuver. So the best treatment for BPPV is this 5-step cyclical maneuver beta called as the Eppler's maneuver. Please tell me beta, what is the 2-step maneuver that we use for treatment? I told you 2-step maneuver that we use for the treatment on a patient of BPPV or a benign paroxysmal positional vertigo. That is not the best maneuver, but still we can use it at times. So Eppler's is the best maneuver for the treatment of BPPV, but in case if they ask you a 2-step maneuver used in the treatment of BPPV, very good. It has to be a Simmons maneuver. Okay, so Simmons maneuver, okay, it's going to be the 2-step maneuver used for the treatment of BPPV beta. Shabash. That is important. Understood? Next important, if they ask you now this question number 11 beta, easy again. Here we are having a metal factory worker beta. We know, okay, metal factory worker means will be loud sound or loud noises beta. Okay, the person is a metal factory worker, suffers from tinnitus, that is a ringing sensation in the ear along with hearing loss beta since the last few months. PTA or a pure tone audiometry has been performed and it shows the below given finding. Okay, which among the following structures will be affected in this patient's condition? Bolo. Which among the following condition will be which among the following structures will be affected beta? Anybody? What is the classical picture on the audiogram? I hope all of you are quite aware. The red lines on the audiogram are going to represent the right ear. The blue lines on the audiogram, you can see beta, it is going to represent the left ear beta. For right ear, we use definitely bache the circle. Okay, so circle or cross. Sorry, for left ear we use the cross beta basically. Okay, this is for air conduction beta. We know close symbols are used for air conduction. Whereas for bone conduction, definitely beta. For the right ear, we can use this kind of a bracket bache, and for left ear this one. तो याद रखना bone conduction के लिए बेटा we are going to use basically the brackets that you have to remember. They're not going to ask you exactly the symbols. Okay, important is this one beta over here. You are able to see that both the air conduction and bone conduction in both the ears beta was actually less than 25 decibel, and whenever both the lines are less than 25 decibel, that is normal hearing. But at higher frequencies when we went beta, now you can see definitely that the bone conduction and the air conduction of the patient became poor. So at higher frequencies, definitely the person was surely having a hearing loss. And you are able to observe a very classical feature that both the air as well as bone conduction in both the right as well as left ear beta is showing you a dip at how many hertz? At 4000 hertz. Please tell me what is this notch called as? Very good. We know beta that whenever air conduction as well as bone conduction beta, whenever air conduction and bone conduction both are going to be poor, and both of them will show us basically a dip beta. Okay, both the air conduction and bone conduction which will show you a dip basically at how many hertz? At 4000 hertz. Either I can call it as an acoustic dip, or which notch? Either I can call this as an acoustic dip beta, also called as which notch? Or the boiler's notch beta. Either I can call it as a acoustic dip or Boiler's notch. That is what is important, beta. Acoustic dip or Boiler's notch is going to be observed. Anybody, if there would have only been a dip at 2000 hertz in bone conduction, if there would have been only a dip at 2000 hertz in bone conduction, beta, then we call it as Carhart's notch, and Carhart's notch will be a case feature of anybody. Carhart's notch that we observe it at 2000 hertz only in bone conduction, that will be a feature of Carhart's notch on audiogram, beta, is a classical feature of autosclerosis. Yes, whenever there is fibrosis around the foot plate of stapes, beta, then that condition is autosclerosis, and in that on an audiogram I am able to get a classical Carhart's notch, beta. That is important to be remembered. Okay, Carhart's notch. Now important is यहाँ पे you are able to see a dip at 4000 hertz in both air as well as bone conduction called as acoustic dip or Boiler's notch. So please tell me what is the diagnosis of the case. Please tell me, beta, what is the diagnosis of the case? The diagnosis of the case is nothing else but what? NIHL. What is NIHL? Noise-induced hearing loss. We know na that whenever Boiler's notch is found on audiogram, beta, it is a classical case of noise-induced hearing loss. As the person was a metal factory worker, the loud noise of machines, beta, would have definitely led to a permanent hearing loss in this patient. Yeah. Now please tell me which among the following structures would be damaged if the person is having a noise-induced hearing loss. We know now due to loud noises, what is going to happen? The inner ear of the person or the cochlea of the person will get damaged, right? The inner ear or the cochlea of the person will get damaged, beta, due to these loud noises. And as the cochlea of the person is damaged, that's the reason the person is having a noise-induced hearing loss or a sensory neural hearing loss, beta. Answer has to be. We know cochlea is damaged. And what is the end organ basically? The sensory end organ of cochlea responsible for hearing is called as organ of Corti, beta. Right? Organ of Corti is the sensory end organ of hearing present inside cochlea, beta, which is actually responsible for processing of sound. But here the cochlea is damaged or the organ of Corti has been damaged. An organ of Corti contains what? Yes, organ of Corti contains the inner hair cells and outer hair cells. Matlab, here the structure which have been damaged, beta, it is nothing else but option C. That is the outer hair cells of cochlea. Right? It is the outer hair cells of cochlea or the organ of Corti which would be damaged. We know now what is crista ampullaris. Crista ampullaris is the sensory end organ of semicircular canal. It is present inside the semicircular canal, and we know semicircular canal is responsible for the angular balance of the body. So if the patient would have vertigo or disturbance in the angular balance of body, then I would have said, beta, that yes, the patient is having damage to crista ampullaris. Next, macula. Macula is the sensory end organ of utricle and saccule, beta. We know macula is the sensory end organ of utricle and saccule. And we know this is actually responsible for linear balance of the body. So whenever the person would have vertigo or disturbance in the linear balance of the body, then I would have said, okay, it is a damage to the macula, beta. Cupula, so it is nothing else but the gelatinous covering of crista, beta. So whenever there is a gelatinous covering over the crista, basically, that is what is called as the cupula. Okay? So cochlea, the only one part was mentioned over here, and that was nothing else but outer hair cells of cochlea. Clear about? Hopefully clear. These are the pictures that you are able to see. Now, if I talk about an audiogram, beta, so we know that whenever a person comes to us with hearing loss, the first audiometric investigation that we do, beta, it is PTA. Either I can go for a tuning fork test or a better investigation than that is a PTA, that is a pure tone audiometry. Please tell me in the chat box, pure tone audiometry will be a subjective test or an objective test, beta. Let me know in the chat box. Pure tone audiometry pe I will check for air conduction as well as bone conduction, beta. We know air conduction is a complete test of hearing, bone conduction is a partial test of hearing. Now when I have to check for air conduction, I will definitely, beta, give earphones to the patient, and with the help of that earphone, beta, the person will be able to hear the sounds. Second time, whenever I have to check for bone conduction, I will place an electrode over the patient's mastoid bone, and then we will make the patient hear the sounds, beta, that is bone conduction. Okay. Important is in pure tone audiometry, beta, we will give the patient different frequencies of sounds ranging from 250 Hz to 8000 Hz. So ranging from 250 to 8000 Hz, different frequencies of sounds, beta, will be given to the patient's ear, and every time we will ask the patient whether he was able to hear the sound or not. And whenever we are asking the patient, but the patient's participation is necessary for this test, beta, so it is a subjective test. Recent FMGE mein they asked you which are the subjective and objective test of audiometry. Yaad rakhna, tuning fork test or pure tone audiometry. Both of them are subjective tests because here the patient's participation will be required. Reason, every time the person is able to hear the sound, the patient is going to tell us whether he was able to hear the sound or not. Okay, please tell me the objective test of audiometry beta in the chat box. Let me know about the objective test that we perform in audiometry. Let me know about that, where patient's participation is not required. Now important is beta, यहाँ पे देख सकते हो, in the first picture you are able to see, I've told you that the dotted line will always represent bone conduction and the continuous thick line will always represent air conduction. Always remember, bone conduction is always the upper line beta. As you are able to see that both the lines are red in color beta, matlab this is an audiogram of right ear. So this is a right ear audiogram that we are able to see. Now in this condition, I have told you the cutoff value is 25. If both the lines are usually less than 25 decibels, that means we can say if they would have been here, if they would have been both less than 25 decibels, I would have said it is a normal hearing. But here you are able to see beta, both the lines are beyond 25 decibels. As both the lines are beyond 25 decibels beta, matlab the bone conduction is poor as well as air conduction is poor. When both the air conduction and bone conduction will be poor beta, it is a case of CHL or SNHL. Let me know in the chat box. If both bone conduction and air conduction, both of them are poor beta, then it is a case of conductive or a sensory neural hearing loss, CHL or SNHL. Yes, the investigations like OAE, that is autoacoustic emissions, or BERA, that is brainstem evoked response audiometry, both of them are objective tests where patient's participation is not required. Okay, that can be done in pediatric patients or malingerers as well beta. Yes, so we know if both of them are poor, that means the cochlea of the patient is damaged. That means it is a case of SNHL or a sensory neural hearing loss beta. Hopefully clear. That is the audiogram of SNHL. Next picture, what we are able to see. Again, the dotted line of the brackets represent bone conduction, or the continuous line of the closed symbols represent air conduction. Bone conduction is always the upper line. Here again you can see the cutoff beta, that is 25 decibel. Here you can see that the bone conduction line is usually less than 25 decibel. Whenever I say that the bone conduction is less than 25 decibel, the bone conduction of this patient is absolutely normal. Second, you can see the air conduction is usually less than 25 decibel. Air conduction is beyond 25 decibel. Whenever air conduction is beyond 25 decibel, air conduction of the patient is poor. Whenever bone conduction is normal and air conduction is poor beta, we know the patient is suffering from CHL, that is a conductive hearing loss. Okay, that is a classical case of CHL or a conductive hearing loss beta. That is what is important to remember. Okay, so these are definitely the important points to be remembered beta. Clear hai baat? Yaad rakhna hai baat. No issues with this? So these are the important points that you have to keep in mind beta. Now other two audiograms beta. This first audiogram is telling you what? Here you are able to see bache that the person is having hearing loss at only higher frequencies. Reason is here, this is the 25 decibel ka mark. Okay. Now important is you can see beta at lower frequencies, both the lines were definitely less than 25 decibels beta. Matlab at lower frequencies the patient's hearing was absolutely normal. But as we check the higher frequencies, you can see beta at higher frequencies the person was not able to hear the sound, and therefore the person was having a high frequency hearing loss. And whenever we know beta there is a high frequency hearing loss, matlab the basal turn of the cochlea has been damaged. Okay? And due to this beta, you are able to get a very classical audiogram. What is this audiogram called as? Sloping audiogram. Very good, yes. And whenever you are able to get a sloping audiogram beta, we have just now discussed, whenever we are able to get a sloping audiogram beta, it is a classical feature of press by accusis bache. Okay, it is a classical feature of press by accusis, that is nothing else but age-induced hearing loss. So it is a classical feature of press by accusis, that is a age-induced hearing loss beta. Hopefully clear to all of you now. Rising audiogram is seen in Meniere's disease, and sloping audiogram is a feature of press by accusis or age-induced hearing loss. Understood? Next important, if I talk about this picture over here, what is seen in this picture beta? Now let me know what is seen in this picture. Here this is the 25 decibels ka mark. You are able to see beta that this is the bone conduction dotted line, this is the air conduction continuous line. Important, you can see beta that the bone conduction of the patient is less than 25 decibel. If the bone conduction of the patient is less than 25 decibel, that means the bone conduction is absolutely normal beta. Second important, here you are able to see air conduction is beyond 25 decibel. Whenever air conduction is beyond 25 decibel, air conduction of the patient is poor. Third point, you are able to see that there is a significant gap between both the lines. Whenever there is a significant gap, more than 15 decibels ka gap between both the lines, that is called as a AB gap. So there is a significant AB gap that is present. We know if all these three features are there, beta, it is a case of CHL, that is a conductive hearing loss. So we know it is a case of CHL or conductive hearing loss. But when you look at one more picture, one more feature, beta, and that feature is you are able to see a dip in bone conduction, beta. And how many hertz? 2000 hertz. You are able to observe a dip in bone conduction, beta, at 2000 hertz. And we know whenever there is a dip in bone conduction, beta, at 2000 hertz, I've just now told you, dip in bone conduction, beta, at 2000 hertz is classically called as which notch? The Carhart's notch, beta. Dip in bone conduction at 2000 hertz, beta, is classically known as which notch? The Carhart's notch. And I hope all of you are quite aware, beta, that whenever there is a Carhart's notch which is going to be found, it is a classical case of otosclerosis. Carhart's notch, whenever it is seen on an audiogram, beta, it is a classical case of otosclerosis or fixation of stapes. Clear to all of you now? That is what is important. Chalo. Next important, if I talk about, beta, is question number 12. It states, beta, a patient presents to you with complaints of oral cavity findings as given below, beta. He gives you a long history of smoking, beta. Okay. What would you choose as your next step, beta, in the management of this patient? What would be chosen as your next step in the management of this patient? Bolo. What should be chosen as the next step in the management of this patient? What is seen? In the oral cavity of the patient, beta, there is a long history of smoking, and in the oral cavity of the patient, beta, I am able to observe a white patch in the oral cavity. Whenever there is a white patch in the oral cavity, I hope all of you are quite aware, it is a premalignant lesion of oral cavity known as leukoplakia. Okay, it is a premalignant lesion of the oral cavity. It is the most common premalignant lesion of oral cavity, beta, known as leukoplakia. We know the risk factors will be: one is smoking, second is tobacco, third is betel nut, fourth is areca nut. Okay, so all of these are definitely going to be, beta, the risk factors for premalignant lesions or cancer, beta. So leukoplakia is the most common premalignant lesion, and erythroplakia is the most dangerous premalignant lesion, beta. So what should be the treatment? Okay, next step in management of the patient, beta. So we know whenever leukoplakia is there, beta, okay, हमें पता है that obviously in this condition, which we know what should be the next step. Option A says give a intralesional triamcinolone. No, intralesional triamcinolone, beta, is given in the case of oral submucous fibrosis. Oral submucous fibrosis जो होता है, beta, in that condition what is going to be there? Please remember, in that condition, sorry, oral submucous fibrosis में the patient will have hypersensitivity to betel nut, and due to hypersensitivity to betel nut, beta, you can see the patient will initially develop ulceration, beta, and later those ulcers are going to heal. Whenever these ulcers in the oral cavity will heal, beta, they will heal with fibrosis. That condition is known as oral submucous fibrosis. This is also a premalignant lesion of oral cavity. And whenever there is a oral submucous fibrosis, the treatment of this condition is intralesional triamcinolone, beta. Important from surgery point of view, we have discussed. So intralesional triamcinolone, which is there, okay, intralesional injection of triamcinolone, which is there. It is the treatment in patients of oral submucous fibrosis. Barabar? If they ask you, beta, that is done or what in leukoplakia? No, that is not done in patients of leukoplakia. That has to be kept in mind. Here, yes, it is used in keloid scar too, but oral cavity mein it is used for oral submucous fibrosis. That is important. Okay. Next, option B says, beta, we have to stop smoking and do biopsy. Yes, you will ask the patient to stop the smoking, which is a risk factor, and you will surely go for a biopsy to rule out whether it is a case of leukoplakia or it has already progressed into the stage of squamous cell carcinoma in the oral cavity. Option C says lifestyle modification. Yes, that would be one of the important steps, beta, but alongside lifestyle modifications like stopping smoking, I will also advise the patient to go for a biopsy immediately, because I don't want the lesion to progress further. Clear about? Option D says CO2 laser ablation. That is not done. The answer has to be option B, beta, to this question. Stop smoking, that is lifestyle modifications, along with get a biopsy done. Reason is, once biopsy confirms, beta, whether it is a case of leukoplakia or a cancer, always get excised, always get it excised, beta. So surgical excision is going to be the treatment in cases of these pre-malignant lesions, beta. Clear? This is the reddish region that you are able to find in the oral cavity. Whenever I am able to see a reddish region in the oral cavity, that is called as erythroplakia, which a red patch in the oral cavity will be called as erythroplakia, and this is the most dangerous pre-malignant lesion, beta, because we know leukoplakia will have 3 to 5 times higher risk of malignancy beta. But we have discussed that erythroplakia has almost 6 to 9 times higher risk of malignancy. ठीक है, erythroplakia almost has a 6 to 9 times higher risk of oral cavity cancer or malignancy. ठीक है, so that is important. Next is question number 13 बच्चे, very common and easy question. Here you are able to see a teacher beta who has been taking frequent long uninterrupted sessions beta. She has been taking frequent long uninterrupted sessions before the final examination of students. He has been complaining beta of hoarseness of voice recently for the last 1 month. ठीक है, so he complains of hoarseness of voice for the last month and says 2 different frequency sounds are going to be heard. When you are able to definitely see beta, the person is able to produce 2 different frequency sound. मतलब his voice is heard in 2 different frequencies beta. That is called as diplophonia. So person is having a classical important symptom of diplophonia. His laryngeal endoscopy picture has been given below. What would be the least likely management of this patient? I'll come to the management later. Pehle, please give me the diagnosis of this case. What is going to be the diagnosis of this patient? What is going to be the diagnosis of the patient? Diagnosis batao pehle. What should be the diagnosis of this case? सोचो वापस. I have told you in the class. I have told you in the class. This is the laryngeal endoscopic picture. Yes, it is unilateral growth. You are able to see a unilateral big growth at the junction of anterior 1/3 and the posterior 2/3 of the vocal cord. At the junction of anterior 1/3 and the posterior 2/3 of the vocal cord, if you are able to get a unilateral growth which is large in size, more than 3 mm in size, it has to be only a case of vocal polyp. The diagnosis of this case has to be a vocal polyp, not nodule. Teacher is not always nodule. Teacher is only signifying that the patient is having vocal abuse. But vocal abuse is a common cause for both the condition. Vocal abuse is the most common cause for vocal nodules as well as for vocal polyp. Hoarseness of voice is again a common symptom in both the condition. Third, for both the sides, both the conditions, the site is also common. Junction of anterior 1/3 and posterior 2/3. So what is the basic difference? We know the basic difference in this patient is nothing else but, yaad rakhna, if it is unilateral and if it is more than 3 mm in size, it has to be a vocal polyp. And if it is going to be bilateral beta, always bilateral, again present at junction of anterior 1/3 and posterior 2/3 of the vocal cord, and it is bilateral and less than 3 mm in size, very small in size. So if it is always bilateral and less than 3 mm in size, okay, that is small in size, then it has to be a diagnosis of vocal nodules. Then it is going to be the diagnosis of vocal nodules. Clear? But that is what is important. So always remember this. Then it has to be the diagnosis of vocal nodules. That's the reason I always say, please remember, always see the picture of the picture that is given properly. That can change. And we know that diplophonia described किया गया. Diplophonia is only a feature of vocal polyp. Diplophonia is never seen in a patient of vocal nodule. ठीक है? Hoarseness can be a common symptom in both the condition, but diplophonia is never a common symptom. ठीक है? याद रखना बात. Teacher is only signifying vocal abuse. ठीक है? So that is what is important. So what should be the answer now? We know what is the treatment for vocal polyp. We know the treatment for vocal polyp is nothing else but the main treatment is the MLS, that is microlaryngeal surgery, where we will use the CO2 laser and we will excise this polyp beta. So CO2 laser excision is the treatment of vocal polyp. Along with that, obviously we can give speech therapy after the surgery beta, and we will advise the patient for a voice rest or a vocal rest because vocal abuse is the cause. In cases of vocal nodules basically, so yaad rakhna, in patients of vocal nodules, the treatment, if they ask you, we know here the main treatment of the patient is going to be a voice rest along with sometimes a speech therapy. So voice rest along with speech therapy beta is the treatment for vocal nodules. But our diagnosis is a case of vocal polyp, and if vocal polyp is the diagnosis, we know that yes, surely we have to go for a CO2 laser excision. CO2 laser excision will rather be the treatment of choice. CO2 laser excision will be the treatment of choice in this condition. Bolo. We know speech therapy, yes, speech therapy will be given in the patient. Okay. Vocal rest, yes, vocal rest will be advised in the patient. There is no oral steroids which are given in the treatment of either vocal nodules or vocal polyp. Whatever you had diagnosed, you had to answer it correctly. That's oral steroids are not used in the management of vocal polyp or vocal nodules. But in case I would have asked you a question about diagnosis, then your diagnosis would have been wrong. याद रखना है बात, ठीक है? Always remember to see the picture carefully, ठीक है? So not all teachers मतलब nodules होंगे. Please remember that. Understood? Question number 14, if they ask you, beta, a patient following peanut consumption बच्चे presented to you beta with complaints of stridor along with respiratory distress and hoarseness of voice beta. So following peanut consumption beta, the patient is having these problems like stridor or respiratory distress and hoarseness of voice with swelling of lips also. What is the most likely diagnosis of the patient? Bolo. Swelling of lips. Well, what is the likely diagnosis of the patient? What has to be your diagnosis? The diagnosis has to be A, B, C or D. Very good. Yes. I hope all of you are quite aware that swelling of lips is nothing else but called as angioedema. Swelling of lip is nothing else but called as an angioedema. Okay, this is what is an angioedema that you are able to see. This is the swelling of lips which will be seen beta. Okay, now important is there are two conditions which are very close. Okay, we know that it could not be a pharyngeal abscess because pharyngeal abscess, as it is pus collection, the patient will have a history of fever, the patient may have pain. Okay, there will be dysphagia, odinophagia. These kind of features will be given in pharyngeal abscess. Quincke's disease. Quincke's disease is nothing else but angioedema, but not an angioedema of lips. It is an angioedema of uvula beta. So whenever there is swelling or whenever there is an angioedema of uvula beta, that condition is basically called as Quincke's disease beta. So Quincke's disease is this. Clear? So that is ruled out. Now options are foreign body bronchus or angioneurotic edema. To rule out, understand. We know if I talk about the foreign body bronchus, तो याद रखना foreign body bronchus में what is going to happen? Foreign body bronchus में बच्चे, the important point is the patient will surely have stridor. The patient would surely have respiratory distress. Patient may have hoarseness of voice. Why? Because there can be obstruction beta which can cause hoarseness of voice, but not very common. ठीक है? But swelling of lips will never be seen. ठीक है? तो याद रखना there will be no angioedema ever in a patient of foreign body bronchus. Why there will be angioedema in patients of foreign body bronchus? Right? So no angioedema and less chances of hoarseness of voice. That rules out our foreign body bronchus beta. Clear है बात? So answer to this question has to be option C, that is an angioneurotic edema beta. Answer to this question has to be option C, that is an angioneurotic edema. What is that? That is the patient was allergic to peanuts beta. We know that definitely as the person was allergic to peanuts bache, okay, as the person was allergic to peanuts, therefore as you have consumed peanuts beta, what is going to happen after consumption of peanuts bache? The person would definitely have an anaphylaxis, an allergic reaction beta, or an anaphylaxis, that is type 1 hypersensitivity, and due to that anaphylaxis beta, the patient will have edema throughout the airway, and as the person will have edema throughout the airway, that will cause laryngeal narrowing, leading to stridor, leading to respiratory distress, leading to hoarseness of voice. Why? Because if there will be edema of the vocal cords, that will cause hoarseness of voice, and even swelling of lips, that is called as angioedema beta. So definitely all these features which are there that diagnose the condition as anaphylaxis or an angioneurotic edema. Hopefully clear. What is the treatment? What is the drug of choice for angioneurotic edema, or what is the drug of choice for anaphylaxis? Anybody? What is the treatment or the drug of choice for angioneurotic edema or anaphylaxis? Answer. The drug of choice for an angioneurotic edema or anaphylaxis. Answer has to be yes. So please remember beta, injection of adrenaline has to be given. Okay, intramuscular or intravenous? Let me know in the chat box. Intramuscular or intravenous, and how much dilution? Adrenaline is considered as the drug of choice basically beta for the treatment of anaphylaxis basically. Okay, and adrenaline should be given via the intramuscular route beta. Here adrenaline should be given via intramuscular route, and that too without dilution beta. So without dilution you have to give it. Without dilution matlab 1:1000 dilution. 1:1000 concentration is there. Hopefully that's clear. So that is what is important. Very good. Shabash. Next important, do this question and then we'll take a break. So here we are able to see beta question number 15, which states a patient was brought to the casualty bache, okay, and an emergency tracheostomy was performed. After a while beta, swelling was observed around the tracheostomy opening, and on palpation beta, crepitus was felt. What is the most likely reason for this complication in the patient beta? Please tell me, what is the diagnosis of this case? What is the complication? Let me know in the chat box. What is the complication that you think? After performing tracheostomy, a swelling was observed beta around the tracheostomy opening, and palpation led to crepitus. Matlab, around the opening, that swelling, when you palpated beta, you are able to feel a crackling sensation. You are able to hear a crackling sensation. That is called as crepitus. So if they ask you that crepitus is there and swelling was there, definitely beta. So please tell me, if crepitus is there, definitely it is a subcutaneous emphysema. Very good. We know beta that whenever there is a swelling along with crepitus beta on palpation, that is a classical diagnosis of subcutaneous emphysema. So the patient's complication that he has suffered beta is a case of subcutaneous emphysema, where the air has been collected around the tracheostomy opening below the skin. So when there is air collection below the skin beta around the tracheostomy opening, that we can call as a subcutaneous emphysema. In this condition, what is the likely reason beta? What is the likely cause? Okay, what is the likely reason for that subcutaneous emphysema to develop? Now option A says beta high tracheostomy. Now we know that the usual site for performing tracheostomy is second and the third rings beta. So definitely bache, high tracheostomy which is there. Okay, it is performed between the first and second tracheal ring. Okay, so high tracheostomy is performed between the first and the second tracheal ring. Okay, and due to this, what will happen? There will be a risk of damage to the larynx beta. As you are performing the tracheostomy between the first and the second ring, which obviously there will be a risk of damage to the larynx, and whenever there will be risk of damage to the larynx beta, the patient may develop a complication, that is laryngospasm. There will be a laryngeal damage, and that can cause a laryngospasm in the patient beta. So laryngospasm hota, so I would have said okay, high tracheostomy would be a likely cause for it beta. That is important. Okay. We know that high tracheostomy is only and only done in one condition. What is that condition where we actually can go for high tracheostomy? Let me know in the chat box. Next, option B says tear to the posterior wall of trachea. Yes, that can be a cause beta. Tear to the posterior tracheal wall can definitely lead to leakage of air, and that air can collect around the tracheostomy opening, leading to subcutaneous emphysema. Let's keep it plus minus. Option C says blockage in the tracheostomy tube. No. Blockage in tracheostomy tube, it happens beta, then the patient will not be able to breathe properly. Okay? And therefore definitely the patient will experience respiratory distress. If they would have said yes, the patient is having respiratory distress or the patient's SpO2 is dropping, then you would have thought of option C, that is blockage in the tracheostomy tube. Okay? So that's the reason beta. Another option says tight suture around the tracheostomy opening. If they said tight suture around the tracheostomy opening beta, yes, this is more common cause for a subcutaneous emphysema. Option B could be the answer, but if I talk about more likely reason, more common reason beta, it has to be option D. That is, after performing tracheostomy, if you apply tight sutures around the tracheostomy opening, then the air is not able to escape out, and some air may get collected below the patient's skin beta around the opening, causing a subcutaneous emphysema. So answer to this question has to be option D beta, more likely. Okay? That is important. Yes, CA larynx or cancer larynx is the condition jahan pe high tracheostomy should be done. Otherwise, high tracheostomy is never done. Why it can be done in CA larynx? Reason: in cancer larynx, we know beta that already the larynx has been damaged. So we don't care about the laryngeal damage beta, and therefore we can go for high tracheostomy. Which clear about? That is what is important to be remembered. Understood? If I talk about tracheostomy beta, tracheostomy is nothing else but an emergency airway of choice. So whenever a person comes to us in emergency with a severe respiratory distress, we will always first try to go for an endotracheal intubation. But whenever beta endotracheal intubation is not possible, we know what are those conditions called as? Let me know in the chat box. Those conditions where endotracheal intubation is difficult, or wherever endotracheal intubation fails, what those conditions are called as? I've told you. Wherever endotracheal intubation is difficult beta, in those conditions we can go for tracheostomy. Or another condition, whenever we need a prolonged mechanical ventilation. This was another PYQ. So whenever a person has to be kept on a mechanical ventilation or a ventilator for a very long duration of time beta, for weeks or months together. So prolonged mechanical ventilation is one of the use or one of the indications of tracheostomy. And another conditions are conditions like maxillofacial injury or laryngeal edema or a bilateral vocal cord palsy. Okay, in these conditions beta, wherever intubation is not possible or intubation fails, all those conditions I've told you will be called as Kiko beta. And when I say Kiko, I hope all of you are quite aware. Kiko का मतलब होता है can't intubate, can't oxygenate, right? All those conditions of Kiko बच्चे, that is can't intubate, can't oxygenate. Okay, like maxillofacial injury, laryngeal edema, bilateral vocal cord palsy. In all these conditions, definitely beta, we should go for a tracheostomy as the next step. Hopefully clear to all of you now. These are the indications of tracheostomy. Now, after performing tracheostomy, we know that what is the best site for tracheostomy. I've already told you beta. Never mark it as C1, C2. C1, C2 is over here. Okay, na? It is the first and the second tracheal ring. Always say it completely. So it is between the second and the third tracheal ring beta. It is always between the second and the third tracheal ring beta. So between second and third tracheal ring is the best site for performing tracheostomy. Now important is beta, after performing tracheostomy bache, we know we can either insert a metallic tube. This metallic tube, what is the name of this metallic tracheostomy tube? Let me know in the chat box. So please tell me what is the name of this metallic tracheostomy tube. So this tube can be inserted beta. It is actually a double lumen tube bache, which you are able to see. But metallic tubes are not used nowadays because there is a risk of corrosion beta. We know na that definitely these metallic tubes can get corroded beta. Okay? There will be a risk of corrosion beta in a metallic tracheostomy tube. That's the reason you are not going to use these metallic tubes nowadays. Rather you use these PVC tubes bache. So we know that these PVC tracheostomy tubes are more commonly used nowadays beta. PVC tracheostomy tubes are of two types beta. One is going to be a cuffed tracheostomy tube, as you are able to see over here, where there is a balloon or a cuff. Second will be an uncuffed tracheostomy tube. So we know that basically this PVC tube which is there beta, it is a cuffed tracheostomy tube. And we know what is the purpose of cuff beta. We know that the purpose of the cuff is nothing else but bache, to prevent aspiration. The purpose of the cuff which is there beta, it is nothing else but preventing aspiration beta. And as the cuffed tracheostomy or the cuffed endotracheal tube helps in preventing aspiration bache, therefore it has to be used in those patients who are having high risk of aspiration. Patients like ICU admitted patient or comatose patient. The patients who are admitted in the ICU or the patients who are in comatose state, but in those kind of patients, we should use a cuffed tracheostomy or a cuffed endotracheal tube. That is important. Very good. Because they help in preventing aspiration. Shabash. And yes, the metallic tracheostomy tube that I have shown you over here, beta, it is nothing else but a Chevalier-Jackson tube. Shabash. So it is the Chevalier-Jackson tube, beta, that you are able to see in the picture. This is a metallic tracheostomy tube that we have. Hopefully clear to all of you now. That is important to be remembered beta. Clear? Most common complication of tracheostomy, we know it is hemorrhage or bleeding beta. But the other complications, as I have told you, it can be tube blockage. Why? Because the suctioning of the tube is not done properly beta, and that can lead to tube blockage, which will cause respiratory distress. Second, it can lead to a subcutaneous emphysema when either there are tight sutures around the tracheostomy opening, or definitely beta, the patient is having rupture of the posterior wall of trachea. Third, the patient will have risk of injury to the other structures. While you are performing tracheostomy, you can injure the patient's thyroid gland or the recurrent laryngeal nerve beta in the neck. Another patient, if the patient is a small child beta, the child can also develop pneumothorax. Reason, the apex of the lung in children goes up to the neck beta, and if you definitely retract too much beta, that can injure the pleura of the lung, and that can even cause pneumothorax in small children while tracheostomy. Patients may also have a apnea beta for few seconds due to a sudden carbon dioxide washout beta after tracheostomy. The patient's respiratory center is not stimulated for few seconds, and that's the reason the patient will have complete stoppage of respiration called as apnea beta. These are the usual complications that you can find after a tracheostomy.